1 2 تست.
ايوه شو بعد 5 دورات
تذكر من مارك الزون تمام؟ مارك الزون ومارك
هذا ما سلكه فين؟ سلكه معايا راح يروح يجي السلك حيكون كذا. أبو كلمة الدكتور لما يجي أديله، الدكتور لما يجي يتكلم أديله الماء. طيب جاهز السنة النشيد الوطني؟ نطف نطيب طف يا ابن سلم طف هذا نكبنا. النشيد جاهز؟ هذا هو جاهز. طيب شغل. الناس في ذرى أوطانهم سكنوا ونحن في قلوبنا يسكن الوطن. النشيد الوطني. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. سعادة المدير التنفيذي لمستشفى النور التخصصي الدكتور وائل بن حسين الميمني، السادة الحضور الكرام، السلام عليكم ورحمة الله وبركاته. نرحب بكم جميعا في هذا الصرح الشامخ والذي نعقد فيه المؤتمر الطبي لحج عام 1443 للهجرة. فأهلا وسهلا بكم جميعا. خير بداية لكل بداية آيات من الذكر الحكيم يتلوها عليكم الشيخ نواف الأركان.
أعوذ بالله من الشيطان الرجيم. وإذ بوأنا لإبراهيم مكان البيت ألا تشرك بي شيئا وطهر بيتي للطائفين والقائمين والركع السجود. وأذن في الناس بالحج يأتوك رجالا وعلى كل ضامر يأتين من كل فج عميق ليشهدوا منافع لهم ويذكروا اسم الله في أيام معلومات على ما رزقهم من بهيمة الأنعام فكلوا منها وأطعموا البائس الفقير ثم ليقضوا تفثهم وليوفوا نذورهم وليطوفوا بالبيت العتيق. ذلك ومن يعظم حرمات الله فهو خير له عند ربه. وأحلت لكم الأنعام إلا ما يتلى عليكم فاجتنبوا الرجس من الأوثان واجتنبوا قول الزور.
حضورنا الكريم، نعيش في هذه الأيام مناسبة عزيزة لدى جميع المسلمين، ألا وهي مناسبة الحج. وفي هذه المناسبة الإسلامية الكبيرة يجتمع فيها حجاج بيت الله في أشرف بقاع الأرض مكة المكرمة والمشاعر المقدسة لأداء هذا النسك العظيم. ويبذل مولاي خادم الحرمين الشريفين الملك سلمان بن عبد العزيز وولي عهده الأمين حفظهم الله قصارى جهودهما لتوفير كافة الخدمات لحجاج بيت الله الحرام لكي يؤدوا مناسكهم بكل يسر وسهولة. كما تبذل الجهات المعنية بهذه المناسبة جهودا جبارة في شتى المجالات لخدمة ضيوف الرحمن. ونخص في هذا المجال الجانب الصحي، والتي تسعى من خلاله حكومتنا الرشيدة للارتقاء دائما بمستوى الخدمات الصحية المقدمة وفق أعلى معايير الجودة لتحقيق جزء أساسي من أهداف رؤية سمو سيدي ولي العهد 2030. الحضور الكريم، يتم الآن عرض فيلم تعريفي عن استعدادات مستشفى النور التخصصي لحج عام 1443 للهجرة. السادة الحضور، الكلمة الآن لسعادة المدير التنفيذي لمستشفى النور التخصصي الدكتور وائل بن حسين الميمني، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. السادة الحضور الكرام، السلام عليكم ورحمة الله وبركاته. يطيب لي أن أرحب بكم جميعا في مؤتمر الحج الطبي لهذا العام تحت عنوان نحو حج صحي وآمن، حيث دأبت مستشفى النور التخصصي على استضافة المؤتمر سنويا لتسليط الضوء على أهم الإجراءات والتدابير الصحية والوقائية والعلاجية للحفاظ على صحة وسلامة الحجاج. وقد عملت المملكة العربية السعودية على تسخير كافة الإمكانيات لتقديم خدمة صحية متكاملة للحجاج وضيوف الرحمن. أخيراً أتقدم بالشكر الجزيل لأخي سعادة الدكتور حسين الباركي وكامل فريق العمل على جهودهم المباركة لإنجاح فعاليات هذا المؤتمر، وأترككم على الاستمرار إن شاء الله ببرنامجكم اليوم. السلام عليكم ورحمة الله وبركاته.
تكريم ده هنا دكتور. استاذنك دكتور، تفضل معاه.
السادة الحضور، الآن مع تكريم السادة المشاركين في المؤتمر الطبي لحج هذا العام. دكتور أيمن يماني، الدكتورة منال القثامي،
صلح المايك كده، صلح المايك.
الدكتور حسن الزهراني، الدكتور قاسم الخطيب. الدكتورة نشوى الخوتاني. الدكتورة مريم الهيبي. الدكتور أسامة أبو العلا. تعال دكتور. الدكتور سالم الشريف. الدكتورة سارة صالح. الدكتور حسان هوساوي. الدكتورة بشرى القرشي. الدكتورة رولا قطب. الدكتورة روزان رضوان. الدكتور محمد فيصل. الدكتور أحمد موسى. الدكتورة ندى فطاني. الدكتور عبد الحسيب. أعضاء اللجنة العلمية لمؤتمر الحج الطبي: الدكتور فاضل الزهراني، الدكتور ماهر غزاوي، الدكتور عبد المعين القرني، تكريم رئيس اللجنة العلمية لمؤتمر الحج الطبي الدكتور حسين البارقي. حضورنا الكريم سيتم بعد قليل استكمال محاضرات مؤتمر الحج. شكرا لحضوركم.
اليوم الصباح حاول 3 مرات تأكيد الحضور، فنعتذر من الدكتور سالم.
نعتذر من الدكتور سالم. يستاهل يستاهل.
الله يعطيك. لا سقطت سهوا، مشاركته فعالة كانت معنا. الله يعطيك العافية.
شكرا جزيلا. شكرا لحضوركم.
إن شاء الله يعطيكم العافية. والله ما قصرت.
خلينا نسجل الناس. خلينا نسجل الناس. لا
فلاش يا سعود. فلاش ايش اخذ؟ فلاش ايوه هذه جاهزة بس
نبدأ. طيب السلام عليكم، يعطيكم العافية جميعا. And we are going to resume our program, and we have the third session. So all the session, most of the topic is related to infectious disease, and this session will be moderated by Dr. Abdulmain. Dr. Abdulmain is an internal medicine consultant, and he's an infectious disease consultant, and he's a head of our infectious disease department. Welcome, Dr. Main, and the floor is yours to moderate the third session for today. Thank you.
I relate to the chairman of contracts in our more than 4 presentation will be because I'm not sure about multiple how actually senior consultant board medicine board in
فين فين المحاضرة؟ كيف؟ أنا ماني سامعتني؟ السلام عليكم. هذا إيش؟ هاي الأفضل الأسهل للإنسان. هذا يطلع صوت ترى زي الهواء، مزعج ترى لو قعدتي هناك. أيوه سمعتني؟ طب حط المحاضرة. أنا أحب هنا.
تحب خلاص شو كذا كتاب كذا ما
من هنا ده.
من هنا أيوه
هي كذا. خلاص. اللي خليكي قريب. طيب. السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم جميعا. It's my pleasure to present an important topic of monkeypox. خذي هذا. Of سامعينني؟ It's clear؟ ما هو clear؟ دكتور سالم سامعني؟ So it's my pleasure to present a monkeypox outbreak update, and thanks for the arranging committee to select me to present the topic. Thanks Dr. Abdul Mu'in Al-Garni for the introduction. So Bismillah ar-Rahman ar-Rahim, salatu wassalam ala ashrafil anbiya wal mursalin. My context for the lecture, I will talk about identify the infectious agent and the mode of transmission of monkeypox, and recognize, and it will be recognized the clinical feature with differential diagnosis, the surveillance, the definition of monkeypox case and the reporting, and also we will concentrate on the list of infection prevention control measure and the start of the laboratory and management and the vaccine of monkeypox. So on the introduction, if we go for the monkeypox, it was initially discovered in 1958. It was an outbreak of pox-like disease occurred in colony of monkey. Because of that, the name it was produced for that. In 1970, the first human case of monkeypox was recorded in Democratic Republic of Congo and became endemic in the part of the Central and West Africa. In 2003, the first monkeypox outbreak outside of the Africa, it was in the United States. From 2018 to 22, there is a frequent reported of the cases outside of the Africa. By 14 of May 2020, a cluster of cases of monkey was reported in the United Kingdom. These cases have no history of travel or travel-related cases. Since the UK reported of the cases, there's a frequent Europe countries started reported of the monkeys cases, and some of them like report the case of this sexual contact. All infection characterized by some we have related to West African clade. The chain of transmission and the reported outside the Africa, it was without epidemiological link to West or Central Africa. As the immunity of monkeypox virus was previously achieved with the vaccine, and due to lack of the vaccine and the effort for that, gives the chance for the monkeypox to come again. So this is the geographic distribution. The geographic distribution of the monkeypoxes, it was reported by the 27th of June, according to the website of World Health Organization, and it was mainly like include the Europe country and the North of America and the South of America. And if we go for the other, this is the website according to the CDC. It was presented by on the 29th of June, but lastly till on the 1st of July, because we represent the presentation early, till the 4th of July, the cases reach up to 6,000 cases in 22 countries. If we go for the Middle East, it is related to United Arab, they have a 13 cases, and Lebanon, they have 1 case, and the rest is related to the Europe, North America, and South Africa. So if we go for the causative agent and the natural of the history, monkeypox is an enveloped double-strand DNA virus, belong to the boxyvirus genes, and it is related to Boxyviridae family. Currently, there is 2 phylogenetic distinctive clade of the virus. It is the Central and the West of Africa. The case fatality around 1 to 10%, and the 10% is mainly related to the Central African clade. The natural host of the disease, it is unknown, but it is well now. It is infected the animals. It is the reservoir for the rodent and the rat and the squirrels and sooty Mangabe animals. If we go for the mode of transmission, it is well now, like it is animal to human transmission and human to human transmission. So for the animal to human transmission, if we go, or sorry, for the animal, it is by infected bite or the scratch or the consumption of bush meat related to the animal. If we go for human to human transmission, it is well now like by face-to-face exposure when there is respiratory secretion and droplet, and also by direct physical contact between the mucous membrane and even the sexual contact, or indirect contact by the contaminated surfaces and the equipment of the infected case. The symptoms and the sign of the disease, there we have the incubation period for the incubation period. It is run from 7 to 14 days and to reach up 21 days. And after the incubation period, usually we have 2 to 4 weeks of the infection. So if we go for the invasion period, usually lasts between 0 to 5 days, and it is characterized by intense headache and fever, reach up 38.5, and also by swelling lymphadenopathy, which is characteristic or distinctive for the monkeypox virus. It is mainly include the cervical, maxillary, and axillary lymph node, inguinal lymph nodes, and it is tense, firm, around 4 centimeters. And also like the fatigue and muscle ache related to the viral illness. If we go for the skin eruption period, it is within 1 to 3 days from the appearance of the fever, and it is like spreading gradually. It started from the face and spreading to the palm and the hand and the sole of the feet. It is involved the mucous membrane and genitalia, and also the conjunctiva of the patients. So you need to be familiar with the skin eruption stage. حسين هذا ايش اللي كده هذا ما يروح اضغط. Yeah. So we need to be familiar with the skin eruption stage, the macule first stage, and the pupule physical, then the pustular stage, and then will be crusted lesion. This is like the typical. This is the typical like implicated papules for the chicken, for the monkeypox. So it is started in the face, involved the palm, and involved the sole, and is distributed centrifuge in the body of the patient with this picture, and involved the mucous membrane and the conjunctiva, maybe involved the genitalia. So we need to be familiar with the surveillance definition of a human case of monkeypox, which is reported to WIQAYA website related to the Ministry of Health. The suspected case defined as the case meet the clinical and the epidemiological criteria. The confirmed case, when we have a suspected case with the positive PCR for the monkeypox virus or by the cultures. The clinical feature, we should be familiar with the case definition of to facilitate the diagnosis and to be solved from our infection. Clinical criteria, unexplained rash, as I mentioned, maculopapular physical pustular rash, with more than 2 of the criteria related to high-grade fever, more than 38.3, and lymphadenopathy, headache, back pain, myalgia, and asthenia, and unexplained rash. We need to be familiar with the rash related to the chickenpox, herpes zoster, and measles, primary or secondary syphilis, to help us in the diagnosis, with the importance of the epidemiological link, and this is a part of the importance of the history. Close contact with the suspected or confirmed cases within 21 days of the onset or recent travel to African endemic areas, one in the Central or the West Africa, within the 21 days of the onset. This is like what's reported in the Clinical Infectious Disease Journal. It is in 2018. It's like a point of article related to the monkeypox. Give you as the distribution of the fever. It is mainly with a small box, more than 40. If we go for lymphadenopathy, it is mainly characterized for the monkeypox. If we go for the distribution, if the lesion, smallpox and monkeypox, it is similar. The lesion distribution, it will be centrifugal in the small and monkeypox, and it is centripetal in case of varicella. The lesion, it is also like hard, deep, well-applicated lesion in the small and monkeypox compared to the varicella. It is superficial, irregular border, and the progression of the lesion, it is mainly slow progression on the monkeypox and smallpox compared to the varicella. It will be like rapidly or fast progression. And this is also reported in the World Health Organization website. It gives you the distribution of the rash and the presence of the lymph node, and the mortality or the death. It is reported with the monkeypox up to 10%. This is some of the picture related to the, if we go for the chickenpox, it is mainly like itchy, scaly, itchy rash. It is an itchy rash, and it is the fluid full with the blisters. And if we go for the this is like a measles. In the measles, there will be like rubeoliform rash. It is a flat spot presented in the whole of the body, and the lesion, it was distributed from the face, the edge of the hair, back of the ear, and the neck distributed to the body. This is what related to varicella zoster rash, and this is the maculopapular rash related to secondary syphilis. It is roughly red to brown distribution, mainly in for the palm and the feet, and this is the typical for monkeypox implicated the pustule of the palm of one infected case. Reporting, this is part of the public health department, and this is an important issue. Once we have a suspected case, we need to be reported to the healthcare facility, and we have the website for that. It is related to electronic health surveillance network HISN, and the email of Ministry of Health. The Will Department know about all the reporting that is related to the public health department in our hospital. And this is some of the reported form. We have immediate notification form related to the epidemiology of the patient, monkeypox investigation form, and also like we have the hospitalization course of the patient, also like with the contact exposure. One of the most important to control the disease, to know about the contact for the patient, and to prevent and to try to do source control to prevent the transmission by the contact. You will probably also they have like the contact list for data collection for the patients. One of the most important issue is the infection prevention and control measure to the monkeypox, and it is related to the guideline presented in 31 of May 2020 in Ohio website. So the most important part, it is early recognition and source control of the cases, application of the standard precaution for all the cases. The most important 10 points of standard precaution include the hand hygiene and also the personal protective equipment, the respiratory protective isolation of the patient, environmental cleaning, cleaning, and medical waste and safety of the staff from any injury or splash of the blood. Once you have recognized a patient, you will put the patient on a standard precaution, and additional precaution you need to put contact, droplet, and airborne transmission precaution. The infection control measure also includes that the patient placement. When you have a suspected case with monkeypox, it needs to be in the single negative pressure room. And if you have a shortage of the room, we can put the patient in single room with a portable HEPA filter. Cohorting, it is only indicated if you have a crowdness of rush of the cases and shortness of the single room. So it is merely the cohorting for confirmed cases. Place the patient with distance between the bed, place physical segregation between the bed, avoid any arousal generating procedures inside the room, and disallow the visitor of any visitor or caregiver for the patients. One of the most important issue, it is the personal protective equipment and the donning and doffing of the personal protective equipment. And it is important to start donning with hand hygiene, your gown and your mask according to the FET test, and a goggle for that. And after that, the wearing of the gloves. During the doffing of the personal protective equipment, initially, the most dirty part, it is the gloves. You will remove it, then you will remove your goggle, and you start it from the back of the head. Try as much you can. Don't touch your mucous membrane, don't touch your eyes or nose to avoid any transmission. And then the removal of the gown to roll it from in to out. And also the fit test, all the equipment, it will be removed inside the room, especially the mask, it will be removed outside the room. Then you will be due for hand washing. Transportation of suspected and confirmed monkey case, as much you can restrict the movement of the patient. Try to be a portable machine beside the patient's home. If it is important to transfer the patient, you need to notify the receiving designation, and those who are transferring the patient, they need to adhere to all the personal protective equipment, and the patient need to put a mask on him and also to cover all the lesions. One of the most important, it is environmental cleaning and disinfections, and it is mostly the person dealing with that to wear all the personal equipment. And also don't forget to clean the high touch area from the edge of the bed and the table and the phone, the curtain, all the high touch area, the knob of the door, because the risk of contamination and transmission of the infection. Even like if you're dealing with the leaning, everything, it will be discarded in the medical waste issue. The discontinuation of the isolation and transmission precaution. Once for the confirmed cases, if the patient you have totally free from the illness until resolution of all the symptoms, and the lesion has been crusted, and the skin started to form a new layer underneath. So in that time, you can remove the precaution from him. For the suspected case, you need to do the test, and to deal with them. If they are stable, they can be isolated at home if it is the surrounding comfortable for that according to the public health, or in the hospital. If they are positive, you will deal with them as a positive case. The third part, it is the laboratory diagnosis. The specific diagnosis for monkeypox, it is the PCR, followed by electronic microscopic and viral culture, but less sensitivity compared to the PCR net. And the most important part is sample correction, also to take all the precaution. The most specific, there is a way according to the stage of the disease, you can take oropharyngeal swab, and if it is the lesion, you can take the skin lesion. It is the mainly the specific to be taken like a three set of the lesion to be collected, and the crust, if there is a crust, or you need to remove the crust part and to take the base of the lesion for swab it. This is what is related, the important for sample collection. You need the dry polyester swab and the plate to remove everything related in the medical waste package for that, and also the transportation. Try to avoid the sealing or of the sample, and all the sample, it will be sent to the public health laboratory in Riyadh. Management of exposed healthcare worker to monkeypox case in the facility related to Waqaya version 1. So this is also depend on how much the exposure, depend on the risk assessment. If it is high risk of exposure, medium risk of exposure, or low risk of exposure, the physician or the healthcare worker, because we receive a lot of panic, but we need from the exposure for that. So you need to be familiar with the high risk exposure and the occupational health. It depends if it is unprotected direct exposure with aerosol generation material within 1.3 meters. This is like a high risk, and you need to activate monitoring for 21 days for the case, and to need also to isolate the healthcare worker and to exclude from the duty, and post-exposure vaccine, it is recommended. And according to that, also the medium risk and also the low risk of exposure, if we have a healthcare worker involved in the care of monkeypox case and not wearing the personal protective equipment and contact within 1 to 3 meters, this is and there is no direct contact with the patient. So this is like a low risk passive monitoring for 21 days, and it is no need for isolation, no traffic exposure, and also it is not indicated for post-exposure vaccine. No risk. This is like if we are wearing the full protective equipment, or that we are dealing with the sampling with full protective equipment. So the risk at that time, it will be 0. If we go for the management part and antiviral, it is related to Saudi protocol for suspected confirmed with monkeypox virus. So if we go for the protocol, it is the classified person or the patient according to suspected and probable case, and also the confirmed case. According to the supportive management, it's mainly like a skin care, and also if we have oral lesion and the conjunctiva, how to deal with it, everything it's written here, and the dehydration measurement to support for the patient. From the medication part, they approved for Brencidovir. It is anti-DNA drugs. It is used twice, the first week and the second week, and it is mainly used for a probable case for the case definition and the PCR positive confirmed cases, and to start the medication with availability within 72 of the establishing the diagnosis. So this is the Brencidovir, but it is not available, but it is recommended till it is available. And also the role of vaccine immunoglobulin, also it was reported in case of severe PCR positive confirmed cases, and in case of unavailability of antiviral medication. This is the continuity of the supportive management for the high fever, and also for the malaise, and we have for poor appetite to deal with that. And this is like a study. It was a clinical feature. They are looking for clinical feature and management of a human monkeypox virus. It's a retrospective observational study. It's run in Liverpool in UK, and it is published in Lancet Infectious Disease in May 24, because we have like a deficiency of literature review for this outbreaks. They include the cases of 7 patients. It is a little bit small study from 2018 till 21, and they are looking for all the demographic. There are 7 patients, 4 of them they are a male, 3 they are a female, and 3 of them they are got the infection from Africa, and the rest they in UK. And also they are reckoned for all the rash distribution, the hospitalization course of the patient. Some of them, the hospitalization up to 39 days. They are looking morely for the viral shedding of the virus because of the risk of transmission and the importance of antiviral and the efficacy of antiviral medication for the patient. And some of them they compare for the treatment. This is the shedding of the virus according to the sample of the blood. At the end of the study, they are mentioned like the Brencidovir, it was found they have developed elevated liver enzyme and discontinue of the medication, and little bit according to them lack the efficacy in the clinical treatment. And it was like a promising with one patient treated with the tecovirimat, the 600 BID. There was no side effect, and there is a shorter duration of viral shedding and hospitalization. It was up to 10 days compared to the rest of the patients. Some of the patients spent around 39 days in the hospital. So they need further study and literature on the antiviral. This is the licensed antiviral medication. according to the website of WHO in 2022 for June, Ticovermet and Brincidovir and Cidovir, and this is the dosing and the side effect. Vaccine immunization, it is mainly indicated in high risk group, and this is similar to the high risk definition of the Ministry of Health. This is the use of vaccine post-exposure prophylaxis. It's mainly in high-risk group, like a pregnant lady, in the children immunocompromised patient, and the patient receiving immunosuppressive medication. And also we have like a pre-exposure prophylaxis, which is mainly for the healthcare worker at a risk for exposure to research laboratory personnel, the lab persons, and also the risk of the pregnant lady. The most important vaccine available, it is the LC16 and Mavipin, or it is the now as Genius. And this is like the difference between ACAM 2000 and Genius vaccines available to be for the monkeypox virus, and a lot of literature is needed. So this is mainly of them and the effectiveness of both of them, and this is like non-replicating, and it is mainly like for the pregnant and for the kids, something like that. And this is like full immune system need to be given because a lot of side effects related to CAM 2000. So thanks a lot for your listening, and infection control is everyone's responsibility. Thank you so much. Thank you.
Adult infectious disease consultant and telemetry consultant. I will review quickly the last updated data about malaria and Mesira and how we are dealing with malaria cases. Well, malaria disease is not the new disease. We are knowing malaria since a lot of centuries. One of the famous examples they get to die from malaria is one of the Egyptian movement came to and from malaria. And also our Prophet Muhammad, peace be with him, his companions, Abu Bakr as-Siddiq, radiallahu anhu, Bilal ibn Rabah, radiallahu anhu, all get malaria and were before called mortality because of having paroxysmal symptoms of fever and chill. Okay. Right. In this session, I will review quickly the epidemiological data and in Saudi Arabia, and also I will address the 2019 guidelines by Saudi Moj, and we will review the discussing the available option to treat. Okay. Okay, thank you. So this is our national malaria drug policy. It is the last updated. This is third edition updated in 2015. So you know the guidelines is need time. And like for example, in March, they need 3 years to update the malaria guideline. Okay. And in case still we are facing malaria, it is most common parasitic infection in Saudi Arabia. Our data, most of our malaria in Saudi Arabia is imported, is not locally transmitted. It was imported from outside the kingdom. We have a local transmission of data, very rare. Most common organism is Plasmodium falciparum and followed by Plasmodium vivax. And this mainly occur in the southwestern region in Saudi Arabia and at the border with the Republic of Yemen. For example, in 2017, there is more than 3,150 cases of malaria. Most of the cases was coming from or imported from outside the kingdom. Only you have one 6% of the cases was locally transmitted, or all acquired in Jazan and Nasir, and 98% of these cases locally transmitted was plasmodium falciparum followed by Farfix, and only 1% was plasmix infection. This is the majority of cases, as we said. Most of the cases, 94% is imported from outside. Only 5 or 6% is locally transmitted. This is the species, was 61% of all imported cases of malaria was falciparum, followed by 5X and or co-infection other malaria. This is the distribution according to the epidemiology. As we say, Jazan is one of the most common area, followed by Mecca. Followed by Mecca, we are mainly the second most common region in Saudi Arabia having malaria cases, because we are receiving a lot of Hajj and Umrah patients. They are mostly imported. And the Saudi Saudi government was having plan to eliminate the malaria from Saudi Arabia, and we about to reach this target in 2015. As you say, a lot of cases, the number of cases in 2014 was about to be very low, and we have our program to be eliminated at 2015. What happened about after 2015? And we have a lot of challenges we faced for program elimination of malaria. We will discuss it later. And this is mainly after the war in the Saudi Arabia with border to Yemen. As you say, after 2015, there is a lot of increase the number of cases of malaria in Saudi Arabia. Come on. This is the explanation why there is increase after 2015. We have a lot of migration across the border from Yemen and from Ethiopia, Somalia. Also, we have more than 10 million employees working at least from 50 countries in Saudi Arabia. And we have Hajj and Umrah season. And also we have possibility of plasmoid virus, which have ability to reoccurrence and failed therapy. So let's start with discussion of malaria. We have, before we are managing the case, any case of malaria, we have 4 questions. If you are answering this 4 questions, you are treating your malaria patient very well, and you protect also the community from malaria. First 2, it is malaria or no? Other 2 questions, what type of malaria and what is the severity of malaria? It is complicated or uncomplicated? One last question will be, what is the appropriate therapy for this case? Let's discuss these 2 questions initially. If it's malaria, any physician, you have to suspect malaria in any patient came with fever and history of travel from any endemic countries, or receiving blood transfusion from each different country. We have to ask about travel history for each patient who came with fever. For diagnosis of malaria, it is very easy to diagnose malaria. We have 3 facilities or modalities to diagnose malaria. The old traditional one is malaria film, which is thick, thin film. Thick will identify the organism, which parasite there is malaria or no. Thin will be identify the species of the malaria. Okay, and what else we have to repeat? As CDC said, we have to repeat the malaria film at least 4 times within 24 hours to say this patient don't have any malaria, because some patients they have low parasitemia level, and in the busy lab they will miss the diagnosis of malaria, which is very dangerous. Second modality to diagnose the malaria is a rapid diagnostic test. We have available, as you said, Ministry of Health was available the AMB rapid test, which is identifying the 3 targets. Mainly we are targeting the rapid diagnostic test. And we have another modality like optimal B test. And all this is considered as alternative, but it's very easy to do. No need for experts to look for microscopic examination. It is a rapid blood test, like pregnancy test. It will identify most of the organism, falciparum or non-falciparum. It's very good sensitivity and specificity. We're using very easy to use. Last modality is PCR. It is not available in MOH hospitals. We have only one PCR for diagnosing malaria, which is available at another institution. We are using very advanced detection of artesunate mutation, like Flail 13 mutation, and we're not using regularly for diagnosis of malaria. Last, for diagnosis of malaria, we have to suspect malaria. Still, the blood film is the gold standard to diagnose malaria. We can use the alternative, either rapid detection test. We have a lot of companies available for this diagnosis. Once we are suspecting malaria, you have to do any patient present with fever, a history of endemic travel, you have to suspect malaria, and you will send blood film plus rapid detection, which available. And once there is malaria, you have to classify the malaria, either complicated or uncomplicated. Third question is B, what is the severity assessment for the malaria? Any patient present with any one of this presentation, we have classified this patient as complicated malaria, any cerebral malaria that having abnormal behavior, or Glasgow Coma scale less than 11, or having history of seizure, and should be nothing more than 2. Previous definition was fever should be, or seizure should be more than 2 within 24 hours, and the new update is only the presence of seizure is indicated for severity. Other prostration, okay, we have to ask the patient to sit up and to examine for prostration. And parasitemia level, you have to contact with parasitology lab to identify what is the index of parasite. Because of more than 5, we have considered it as severe malaria. Hypoglycemia, also blood glucose less than 40, renal impairment, and severe anemia. We have hemoglobin less than 7, we have to consider it as severe malaria or diarrhea. Jaundice, if the patient present with total bilirubin more than 3, we have to consider it as malaria. Hemodynamically unstable patient, we have to consider as severe malaria. Either he have shock or pulmonary complication, ARDS, acute lung injury, or severe metabolic acidosis, or severe thrombocytopenia. The last question will be, what is the appropriate therapy for this patient? Either he have complicated or uncomplicated malaria. The rule is, usually we are using combination therapy for treatment of malaria. We don't use immunotherapy because the monotherapy is used. The most common use of combination therapy is ACT, artemisinin combination therapy. Artemisinin combination therapy usually is very effective when tolerated, when having very good, and also it is having a role in dermatocyte reduction, which is as having public protection. First line for uncomplicated malaria, as we said, artemisinin combination therapy plus either, for example, artemisinin plus sulfadioxide pyrimidamine or mifeloquine. This is the doses for uncomplicated malaria, and even the patient should receive 1 dose of pyrimidamine at the end of therapy as dermatocyte reduction. Second line of treatment is also, as you said, artemisinin combination therapy, oral artemisinin plus lumefantrine, which is available in one combination. Third line of therapy is atopic protein plus or oral quinine plus doxycycline or clindamycin. For all patients, we have plasmoid falciparum. At the end of therapy, we have to give him a single dose of pyrimidamine, even if he is G6PD, because of the maximum dose was 50, because of, as we said, dermatocyte reduction is having of the public health issue. So we have it one of the WHO recommendation for eradication of malaria. For complicated malaria, it is true emergency. Each delay, that meaning there is risk of death. So we have to give the IV medication, ACT, artemisinin combination therapy. Even if it is no IV access or you are in facility, we don't have IV lines, you have to give IM or rectally in the children, or you have to give another ACT, RIV, IM artemether. Once the malaria is detected, now we'll discuss in pregnancies. As we said, severe malaria should be treated with IV, including the pregnancy. As we said, pregnancy is in the first trimester, contraindicated to give ACT therapy unless it is severe malaria. You can give artesunate combination therapy. Okay, this is once it happened, we are suspecting treatment failure. We have to call the infectious disease department and to dealing with this case, and we define treatment failure as delaying clearance more than 72 hours of parasites or parasitemia. And we have to suspect, we have a lot of recommendation to do in patient we have delaying clearance from parasite. And this is the doses. We have to give a 0 point and 12, 24, and 36, and 48, and then based on the clinical response, if the patient is rapidly reduced in parasitemia level, we have to change to oral therapy. Another alternative for treatment of severe malaria, we are giving IV artesunate plus methyl or sulfadioxide pyrimethamine. Second line will be intramuscular artemethamine or plus sulfadioxide or methyl or lumefantrine. Rarely we are using IV quinine because of the risk of hyperglycemia and arrhythmia. When this patient should be in ICU connected to monitor, so we're dealing with IV quinine. Other species, we are saying Saudi Arabia is maybe and the local transmission of falciparum. We have 2% about plasmoid vivax. We are dealing with plasmoid vivax. Most of the plasmoid vivax is chloroquine sensitive. We are using chloroquine. Plus, we're saying that it is having hepatocyte phase, which is causing the treatment failure, plasmoid vivax and malaria. And we have to treat with primaquine for eradicate the hepatozoite in the liver. This is the, as we said, worldwide, we have in Kingdom of Saudi Arabia, most of the cases is falciparum, followed by vivax. As we said, dominant liver stage, we have to treat with primaquine for at least 7 to 14 days. In pregnancy, as we said, pregnancy we consider it as severe unless it was for uncomplicated in pregnancy. You have to give oral quinine plus clindamycin, which is recommended. ACT therapy is not recommended in the third trimester unless it is severe malaria. We have to give IV artesunate regardless the pregnancy trimester. Last, malaria is still the most parasitic infection in Saudi Arabia. It is prevented when we have a lot of preventive measures and even chemoprophylaxis for the patient overall, for those who are traveling to endemic area, and early diagnosis. And also we have vaccines nowadays in phase 3 trial for children for prevention of malaria. Early diagnosis, it is crucial for treatment of malaria, and we have more than 12 new drugs available for in the Bible for future, inshallah. ACT nowadays is the standard of care for patient with malaria, and we have to consider malaria in our differential diagnosis. And that means delaying in treatment is meaning death. Thank you. Okay. Next speaker will be Dr. Nada. Dr. Nada, she is internal medicine consultant and infectious disease fellowship. F2, she is about to be graduated from our fellowship program, and she will talk about the MERS, COVID, and COVID pneumonia update about the protocol and what is the management policies.
باكستان عشان يوتيوب.
هذا حلو كده. طيب لا خلاص. السلام عليكم ورحمة الله وبركاته everyone, and good morning for all. And I want to thanks to the scientific committee to give me this opportunity to participate in this Hajj conference. I'm going to talk a brief about the COVID-19 and MERS-CoV, the updated last protocol of MOH. So I will focus on the management. This picture only just to remind us about the past 2 years that how the COVID-19 pandemic affects our life, especially Ramadan and Hajj season. And hopefully, inshallah, this Hajj season will be safe and successful, inshallah, without any infectious disease. So COVID-19, some introduction. The coronaviruses are a large family of RNA viruses that causes illness, ranging from a common cold to more severe disease such as Middle East Respiratory Syndrome and severe acute respiratory syndrome. The new strain of coronavirus was identified, as we know, in December 2019 in Wuhan city of China. Back to the history that in the first of 2003, there was the SARS-CoV virus, which caused severe acute respiratory syndrome, and the first case was reported in China. Then in 2012, we have the MERS-CoV, which was Middle East Respiratory Syndrome, and first case reported in Saudi Arabia was in September 2012. Then we have the last COVID-19, and which reported in December 2019. Regarding these numbers, updated till the 28th of June, till I submit this presentation, taken from the COVID-19 dashboard, with the total numbers cases of 793,729, with active cases 9,570, and total death 9,205. Later on, I will share you the visual triage, but we'll talk about the clinical presentation. Almost the same in the MERS-CoV and COVID-19. Many patients will come with fever, headache, generalized fatigability, rhinorrhea, loss of smell and taste, cough, shortness of breath, pneumonia, GI symptoms including nausea, vomiting, and diarrhea. Regarding the transmission, still there is not much information about the SARS-CoV-2 to draw a definitive conclusion about transmission mode. The transmission of the virus mainly through droplet mode, less frequently through contact. It can be transmitted as well through arousal in cases in aerosol-generated procedure and close contact in indoor settings. So still investigation are currently in progress. Regarding the diagnosis, before we are using the PCR, but nowadays we have the rapid diagnostic test, which is the rapid antigen testing for SARS-CoV coronavirus 2. And it simply detects the antigen of the virus in respiratory secretion, and it's widely be used nowadays in the screening clinic, such as Tatamman, for screening and diagnostics purpose for symptomatic suspected cases or close contact. And it's also very rapid. We will have the result in less than 15 minutes. It's like a pregnancy test and easy to be used, no need for expert or training. Rapid antigen test interpretation, this is taken from the Uqaya or related MOH. So if we have the cluster in closed places, we will do the test. If it's positive, we will treat it as a confirmed case. If it's negative, we will perform another rapid test in 48 hours.
And if it's came negative, we will exclude the COVID-19. If positive, we will treat it as a confirmed case. For the screening clinics, if the patient is symptomatic, we will do the test. If it's positive, we will treat it as a confirmed case. If negative, we'll perform PCR in the same visit of the clinic. If the patient is asymptomatic and the test is positive, we will treat as a confirmed. If negative, we will do isolation protocol. The management of the COVID-19 by the Saudi Emergency protocol for patients suspected confirmed with COVID-19. This is the version 3.6, which released in April 14, 2022. I'll try my best to summarize the tables. So if we have a suspected case, symptoms with no shortness of breath, we will go with a supportive treatment. If the patient had symptoms with or without shortness of breath, but in high-risk patients, we will discuss with the ID to initiate empirical antiviral therapy while awaiting the results. And the recommendation also do not stop AC and ARBs inhibitor in patients with hypertension, post-MI, and heart failure, because the previous protocol was recommended to stop it, and was I think it can increase the risk of the severity and mortality. But nowadays, it's not more recommended. The high-risk patients, they are elderly, age more than 65, or with underlying end organ dysfunction, diabetes, history of cardiac or pulmonary disease, immunocompromised, and pregnancy. For the confirmed cases, there is asymptomatic, which is no need for any treatment, mild to moderate, severe, and critical. Mild to moderate, the patient had symptoms, but there is no oxygen requirement and no evidence of pneumonia, but the patient had other symptoms like a fever, headache, or GI symptoms. The severe cases, who are patient clinical signs of pneumonia, fever, cough, dyspnea, fast breathing, and one of the following: respiratory rate more than 30 in adults, 40 or more in children, oxygen saturation less than 93% in the room air, or severe respiratory distress. Critical patients who had an ARDS, respiratory failure requiring ventilation, sepsis, or septic shock. We recommend that it's recommended in the severe or critical patient to send a baseline lab, because they are risk to have cytokine storms. So the baseline will be interleukin 6, ferritin, D-dimer, LDH, and CRP. This is the criteria for a patient at high risk for developing cytokine storm. One or more of the following: serum interleukin 6 3-fold or more upper normal limit, ferritin more than 300 with doubling within 24 hours, D-dimer more than 1, ferritin more than 600 at presentation, and LDH more than 250, CRP more than 75 milligrams per liter. For the management, we divide the case also mild, moderate, severe, and critical. For mild to moderate, we have 3 modalities of treatment, including the supportive treatment. So we have the inhaled Pulmicort, ritonavir booster, nirmatrelvir, Paxlovid, and molnupiravir. In case of new onset, cough and fever, or insomnia, or both, within 7 days, consider inhaled budesonide Pulmicort 2 puffs twice a day until symptom resolution. For non-hospitalized patients at high risk for disease progression, to consider to give ritonavir boosted nirmatrelvir, the Paxlovid, or molnupiravir. The dose for the Paxlovid more than 12 years and weighing more than 40 kg is nirmatrelvir 300 milligram plus ritonavir 100 milligram BID for 5 days. For the molnupiravir, 800 milligram BID for 5 days. This is the inclusion and exclusion criteria to giving the oral antiviral. The age more than 12 years and more than 40 kg for Paxlovid, 18 years or more for molnupiravir. And also the patient at high risk for progression to severe COVID, like hospitalization or death, and it's recommended to start it within 5 days of the symptoms onset. For the severe cases, the modality will be systemic corticosteroid, remdesivir plus baricitinib, which is anti-RAC agents, plus the antibiotic or antifungal according to the patient's situation. For the systemic corticosteroids, for all patients who require supplemental oxygen, including those requiring non-invasive and invasive ventilation, to be used up to 10 days until discharge or if patient become asymptomatic. The preferable systemic corticosteroid is the dexamethasone with the adult dosing 6 to 12 milligram once daily, oral or IV. Patient on chronic steroid follow the usual recommendation of doubling steroid dose or start the stress dose steroid based on clinical patient condition. Or we can use the prednisolone or hydrocortisone or methyl prednisolone. Remdesivir, it's recommended to be started as early as possible, but it will depend on the patient clinical situation and the discretion of the treating physician, as it cannot be given in patients who have creatinine clearance less than 30 or patients who are risky to be suspected to be on inotropic support or organ dysfunction. The adult dose is 200 milligram loading over 30 minutes, followed by 100 milligram daily for 5 to 10 days. The pediatric dose less than 40 kg, 5 milligram per kg loading, then 2.5 milligram per kg OD for 5 to 10 days. If in pediatric, more than 40 kg, same of the adult dose. In case of corticosteroid contraindications, consider remdesivir and baricitinib once available. The adult dose will be remdesivir 200 milligram loading and then 100 milligram once plus baricitinib 4 milligram oral daily for 5 days. The pediatric dose for the baricitinib more than 9 years will be 4 milligram oral once daily for 5 days. If 2 to 9 years, 2 milligram oral once daily for 5 days. For the critical cases, like the severe cases, including systemic corticosteroid, remdesivir plus baricitinib, with addition to tocilizumab with the dexamethasone. If rapid respiratory decompensation due to COVID-19, consider tocilizumab with dexamethasone. The adult dose is single dose of tocilizumab 8 milligram per kg of actual body weight, maximum 800 milligram by IV infusion, in combination with dexamethasone 6 to 12 milligram daily for up to 10 days. If tocilizumab IV is not available, we'll use subcutaneous injection 162 milligram. The dosing above the patient, if it's a weight less than 100 kg, we will use 2 simultaneous injection, and the total dose will be 324. If the patient is 100 or more kg, we will use 3 simultaneous 162 milligram injection as a total dose 486 milligram. The criteria for using tocilizumab is to be within 24 hours of ICU admission for mechanical ventilator, non-invasive ventilation, high flow nasal cannula oxygen, and also in patients who are exhibiting rapidly increasing oxygen need while on dexamethasone and have CRP 75 or more milligram per liter. Part for the management, the thromboprophylaxis. Therapeutic doses should not be offered because the risk of the bleeding, but the thromboprophylaxis with lower molecular weight heparin should be considered in all patients, including non-critically ill, within 24 hours of hospital admission for COVID-19 infection, in the absence of any contraindication, like active bleeding or platelet less than 25. In patients who had severe renal impairment, we will keep on monitoring them. The abnormal PT or PTT is not a contraindication for thromboprophylaxis. Adult enoxaparin prophylaxis dose 40 milligrams sub-Q daily. In patient BMI more than 40, it will be 40 milligrams sub-Q BID. Pregnancy 40 milligrams sub-Q daily. And renal impairment, if the creatinine clearance more than 30, no need for adjustment. If less than 30, we'll use 30 milligrams sub-Q daily. For the dialysis and the CRRT, avoid use if possible, but if it's used, we will need anti-factor 10 level monitoring. In high-risk patients, like a VTE score of 4 or more, or 2 to 3 with a D-dimer more than 500, it's recommended to give open discharge apixaban 2.5 milligram BID or rifaroxaban 10 milligram per day. Regarding the discontinuation of isolation, we will see, on the first, we will see the immunization status of the patient. If the patient already vaccinated, we will see he is symptomatic or asymptomatic. If the patient asymptomatic, we will count 7 days from the test positive. If the patient is symptomatic, at least 7 days have passed since the symptoms started, and resolution of fever for at least 24 hours without antipyretic. If the patient is not immunized, we will look for the severity. If it's mild, it will be at least 10 days have passed since the symptoms started, and no fever recorded in the last 3 days, and improvement of the other symptoms. In severe cases, we will look to the immunity of the patient. If the patient is immunocompetent, we will deal as a mild cases. If the patient is immunocompromised, it will be at least 21 days passed since the symptoms started, and no recorded fever for the last 3 days without antipyretic, and improvement of other symptoms, or at least 3 days have passed since recovery, and followed by 2 negative respiratory samples 24 hours apart. Okay, now we want to talk briefly about the MERS-CoV. The introduction, as we said before, it was first identified in Saudi Arabia in September of 2012, and approximately 35% of the reported patients with MERS-CoV have died. Although some human cases of MERS-CoV have been attributed to human infection in healthcare setting, current scientific evidence indicates that dromedary camels are a major reservoir host for the MERS-CoV virus. This is a number of cases between September 2012 until 28th of February 2022, as a total cases of 2,585, about 201, more than 2,100 are in Saudi Arabia. The total death was 891, and the case fatality rate was 35%. Distribution of the cases and death from MERS-CoV in Saudi Arabia from 2012 and 2021, and this is taken from the WHO, as we see here in the beginning of the outbreak from 2012 to 15, and now it's decline. Case definition, the suspected cases, this is taken from the MOH guidelines for the MERS-CoV was in April 2018. The clinical presentation, we have severe pneumonia with the severity score 3 or more, or ARDS. Unexplained deterioration of chronic condition of patient with congestive heart failure or CKD, acute febrile illness with or without respiratory symptoms, or GI symptoms with leukopenia or thrombocytopenia. The last two clinical presentation will be linked to the exposure history within 14 days, like exposure to confirmed case of MERS-CoV infection or visit to a healthcare facility where MERS-CoV patients has recently been identified or treated, or contact with dromedary camels, or consumption of camels product like raw meat and raw meal, unpasteurized milk, and urine. This algorithm for managing suspected case of MERS-CoV patient, as I mentioned, this is from the guidelines in April 2018. So maybe if we have some increasing in the number, maybe this could be changed. So if you have suspected cases, we will imply the precaution and we will take the test. We will take the test. We'll send the sample PCR of the or rapid test, and we will see the patient indicated for admission or not. If not indicated, we will apply the home isolation and waiting the result. If it's came negative, we will discontinue the isolation. If it's positive, we will reassess the clinical condition of the patient and to be and assess him if he need admission or not. If still no need for admission, we will keep in home isolation and we will repeat the testing after 7 days. If it's negative, we will discontinue the isolation. If it's came positive, we will repeat every 3 days until we have a negative results. If the patient was in the home isolation and we are reassess him and you need the admission, we will admit him to other negative pressure room or a single room with a portable HEPA filter, and again we will repeat it after 7 days. If it's negative, we will see the patient is ICU patient or non-ICU patient. If it's ICU patient, we will need 2 negative samples. If in non-ICU patient, we will need only 1 negative sample. And if it's came positive, we will repeat it every 3 days. From the beginning, if the patient needs admission, we will follow almost the same protocol. Regarding the management, no vaccine or specific treatment is currently available, although several MERS-CoV specific vaccine and treatment are in the development. Treatment is supportive and based on the patient clinical condition. But nowadays we have this miracle trial. It is the large trial in Saudi Arabia. It is the first RCT for MERS-CoV treatment, and it's a 2-stage double-blinded multi-center placebo control who is compared titled with the treatment of Middle East respiratory syndrome with a combination of lopinavir, ritonavir, and interferon beta-1b. And its the recruitment started in November 2016 and still it's ongoing. But the prelim analysis showing that the combination is lowering the mortality at 90 days than the placebo, and the effect was greatest when started within 7 days after symptoms onset. This is the visual trial checklist for the acute respiratory infection, and it excludes both COVID-19 and MERS-CoV in the exposure risk with some clinical signs and symptoms, and according to the score, we will classify the patient to suspected or not. This is the reporting form for the COVID-19, and there is another one for the MERS-CoV. I finish here. For more information, you come back to the Wiqaya and MOH protocol and WHO. Thank you. عادي.
Good morning, everybody. I will talk today about CNS infection. Actually, it's a very huge, large topic, CNS infection. It cannot be covered over 20 or even 30 minutes. So I will focus only about common CNS infection, which we saw it daily and especially among Hajj season. I will go through this object, definition, clinical feature of suspected CNS infection, different causative organisms, CSF analysis, management, antimicrobial therapy, role of steroid, and prevention. We start with the definition. Everyone will know meningitis, inflammation of membrane surrounding brain and spinal cord, which is three layer, dura and arachnoid and biomatter. In this study, the epidemiology of invasive meningococcal disease in our kingdom, the graph in the letter C show the most causative organism is a pneumococcal, and in the graph letter E, the most common age group is between 5 and 14. The table illustrates the same data. The most common causative organism is a pneumococcal. The data is enrolled and collected between 2012 and 19. And age group also, it's common between 5 and 14, more among male than female, and more in Saudi national. Here we clinical evaluation of adult with suspected meningitis. They enrolling 297 adults with suspected meningitis and had LB. 27% had true meningitis. Headache was the most common presenting symptoms, followed by fever, nausea, vomiting, photophobia, and neck stiffness. The majority, up to 81%, have more than 2 symptoms. When comparing the two groups, the patient with meningitis, 92% have headache, 71 fever, 70 nausea, vomiting, 57 photophobia, neck stiffness 48%, and focal neurological seizure 18%. Comparing to other group is a similar percentage. Regarding the sign, high temperature up to 43%, neck stiffness 30%, Kerning and Brodzinski sign not exceed 5%. Deterioration level of conscious is up to 10%. The percentage also similar to other groups, but the main difference was the mean cell count, CSF cell count. In the meningitis patient, it's high up to 359. Early meningitis symptoms may mimic flu, and symptoms may develop over several hours or over few days. In addition to their previous symptoms, there is some symptoms like sleepiness or difficulty walking, no appetite or thirst, and skin rash, which give us a clue that the most likely causative organism is the meningococcal. So just focus on the triad, headache, fever, and neck stiffness, because it's 85% of the patient with meningitis come with it. Knuckle rigidity is resistant to passive flexion, and turning is extension to the knee with a thigh flex, pain elusate, and neck flexion. Brodzinski, flexion of the neck cause hip flexion, and this is a picture of the maneuver of the two signs. In addition, up to 20% cranial nerve pulse, third, sixth, 7, and occasionally focal neurological deficit. Just keep in your mind the extreme of age, neonate, and elderly. The classical symptom signs may be absent in those patients. Why it's important of early recognition of CNS infection? It's very high mortality and permanent disability, and common feature in presentation and sequelae of very serious condition like bacterial meningitis, TB, viral, brain abscessing, fungal, and polio. So we cannot pass CNS infection without talking about acute bacterial meningitis. It's very common and serious medical emergency. 100% is curable if treated, and at the same time 100% fatal if missed. It needs a very high suspicion of index and then confirmed by CSF. Clinical feature, same the symptoms I mentioned before. It will be sudden in onset with symptom signs of increased intracranial pressure, hypertension, bradycardia, bulging AF, third and sixth cranial nerve palsy, breathing abnormality, papilledema, and rash if the meningococcal meningitis. Here's a picture of late presentation of meningococcemia. Just keep in your mind the other differential diagnosis of petechial rash. Could be staph strep bacteremia, could be viral hemorrhagic fever, low platelet vasculitis, spotted fever, and trauma. Complication of acute bacterial meningitis could be subdural effusion, empyema, vasculitis, abscessing sciatic, hydrocephalus, and infarct. And the sequelae, it will be neurological deficit, deafness, epilepsy, and hydrocephalus. The differential diagnosis can be divided in infectious and non-infectious. The infectious differential diagnosis could be cerebral malaria, enteric encephalopathy, Shigella encephalopathy, sepsis, tuberculosis, viral, and aseptic. Here, the most important part, the common etiological positive organism of acute bacterial meningitis, as I mentioned in the first study epidemiological data, the Streptococcus pneumonia is the most common and account of half reported case secondary to pneumonia, otitis, or splenectomy or diabetes. We noticed up to 45% of Streptococcus pneumonia have a resistance to penicillin and up to 10% to cephalosporin. It's commonly cause of pneumonia or ear and sinus infection. The good thing is the vaccine can help to prevent this infection. It's highly recommended. Next, Haemophilus influenza. Before it was common, but after introduced the vaccine is less than 10%, but still we noticed among immunocompromised patients and elderly. Next, Meningococcus Mesira meningitis. It's secondary to asymptomatic nasopharyngeal colonization. And the bacteria commonly cause upper respiratory tract infection, but can cause meningococcal meningitis when they enter bloodstream. It's highly contagious, especially among the mass gathering and overcrowded among the adult and teenager. Also, the good thing here is a vaccine can help to prevent infection, which is mandatory to all pilgrims this season and all healthcare workers. Listeria we can find in unpasteurized cheese, hot dog, and lash meat is common among extreme of age and immunocompromised and can cross the placenta barrier and infectious to the late pregnancy may be fatal to the baby. This is the commonest organism, but we need to consider some organism for a special population. In the neonate, just consider the gram-negative E. coli and the trauma or neurosurgery patient. We need to put on the top staph and MRSA and enteric gram-negative. This is keeping in your mind during clinical examination. If the patient they have a rash, particularly in the extremity, erythematous, macular, evolving, keep in your mind meningococcus. Otherwise, patient with rhinorrhea or otorrhea, they suspect Streptococcus pneumonia. Pathophysiology. Bacteria spread by droplet and colonize nasopharynx. Bacteremia then meningeal spread through choroidal plexus, epithelial cell, multiply rapidly because absent of immune system, stimulate inflammatory marker. The scheme here show the details of pathophysiology, invasion of subarachnoid space by meningeal pathogen, then multiplication of organism, and lysis of organism by bactericidal antibiotic, release bacterial cell wall component, production of inflammatory cytokine. A lot of things will happen, lead to increased intracranial pressure and finally coma. So if we summarize, alteration in blood-brain barrier with vasogenic edema plus loss of autoregulation and entry of polymorph with cytotoxic edema, so formation of purulent exudate, hydrocephalus, narrowing artery in subarachnoid space and invade wall, continue rise of intracranial pressure and coma. How we can diagnose it? As I mentioned, first, second, third, till 10th, high suspicion of index is very important. Then you compare with CSF, LB defer if there is contraindication, start empirically antibiotic. On suspicion. In CSF analysis, we notice high pressure, turbid cell count, mainly neutrophil, high protein, low glucose, and also we send for culture, gram stain, latex, and imaging. In this picture, any patient with meningitis need to send CSF analysis as a standard test from 1 to 6. Appearance, opening pressure, cell count differential, glucose, protein, culture, and gram stain. From 7 to 11, it's individualized case by case, according to history, examination, traveler history, and etc. If we suspected TB, sent for TB workup. Brucella, sent for Brucella serology and PCR. If there is meningoencephalitis, sent for HSV PCR and multiplex viral PCR. In immunocompromised patients, think for Cryptococcal Meningitis and sent for antigen. The table shows the difference between bacterial, viral, tuberculous, Cryptococcus among the cell count differential, glucose, and protein. If we focus on bacterial, we demonstrate the high count in bacteria up to 5,000 with predominant neutrophil with low glucose and high protein. Positive gram stain culture up to 90%, but this percent it will be low if the antibiotic is started before LB. And blood culture, it will be positive up to 50%. CT will be abnormal if we have seizure, evidence of intracranial pressure increase, CNS disease, immunocompromised, elderly, and abnormal neurological exam. Regarding treatment, as we mentioned, we will cover the common organism, possibility of common organism by ceftriaxone, third generation cephalosporin, and vancomycin for the possibility of Streptococcus pneumonia resistant to beta-lactam. And if we suspected listeria, we need to add ampicillin. And if there is trauma or base skull or fracture, we need to consider to cover staph and especially MRSA, and it will cover by vancomycin. Steroid, it will be added before the started antibiotic, and it's to prevent the sequelae of meningitis. Don't forget, supportive treatment is very crucial and important. And treatment of contact, especially contact public health for meningococcus and Haemophilus influenza with rifampicin or ciprofloxacin, and prevention it's only by vaccination. Vaccine against Haemophilus influenza, pneumococcal vaccine, and meningococcal vaccine. And don't forget to follow infection control measure with wash hand, good practice hygiene, and cover mouth because the mode of transmission is a droplet. Regarding the steroid, few words about the steroid morbidity and mortality of meningitis related of inflammatory reaction rather than bacterial themselves. So steroid inhibit the inflammatory marker and CSF outflow resistant and stabilized blood-brain barrier. The available evidence on adjuvant steroid therapy confirms the benefit for treating Haemophilus influenza type B in reducing otological sequelae and suggesting benefit in reducing otological and neurological sequelae in Haemophilus influenza type B and pneumococcal in kids. There is 18 RCT. They show lowering mortality, hearing loss, neurosequelae, lowering hearing loss, and lowering mortality. And 5 RCT in the adult overall mortality and neurosequelae 0.6, pneumococcus mortality 0.5, meningococcal sequelae 0.5, and mortality 0.9, and no increased side effect with the steroid. We finished the most important point in the acute bacterial meningitis. Next is the chronic meningitis. And when we said chronic meningitis, we highlighted on the tuberculous meningitis. It will be chronic meningitis develop over 2 weeks or more. Symptom size similar as acute meningitis, but on prolonged period. And the risk factor who patient contact or recent infection, measles, young age, pathophysiology, primary infection, bacillemia, hematogenesis, seeding of meningitis, and rupture. Clinical feature, it will be divided on 3 stages. First, pre-dormal, then neurological manifestation, and third is coma. Differential diagnosis of could be partially treated bacterial meningitis or other CNS infection. On CSF confirmation test is CSF examination. It will show high pressure cell count up to 500, mostly lymphocyte, and high protein, low glucose. And we sent for TB workup, acid fast culture, and PCR. Sequelae and complication as a bacterial meningitis, hydrocephalus, optic neuritis, focal deficit, epilepsy, and treatment as pulmonary TB, extrapulmonary TB, first line anti-TB, but the duration it will be prolonged. We need to highlight it on neurobrucellosis because we are endemic area also of brucellosis is one of serious infection, a CNS infection. with the Brucella multicesis, which causes a most severe disease, and Suez, which more cause associated with abscessing formation. It's one of the zoonotic infection, and treatment is very challenging and difficult because we need monotherapy. We cannot work maybe triple or quadruple anti-Brucella therapy, and we choose the one which can pass in the blood-brain barrier for long duration, up to 12 months, maybe. So think of that if the patient has history of Brucella, and from the history they come with the CNS manifestation. Next, I will talk about viral meningitis. It's very important. Most of common meningitis can be secondary to viral. It's inflammation response to viral infection of leptomeningeal cell and subarachnoid space, account of the majority, at least 70% of case of aseptic meningitis. It can be mild and often self-limiting. Most common causative organism, enterovirus, Coxsackie, and ecovirus, followed by mumps, arbo, herpes, HIV in seroconversion state. And viral meningoencephalitis could be dengue, entero, herpes, maxo, paramaxo, adeno, and rhabdo. Also, the clinical feature is based on 3-stage pre-dormal, acute encephalitis, and convalescent stage, improving coma and extrapyramidal. CSF, it will be clear, normal or high protein, normal sugar. It will be diagnosed by PCR specifically. And CRP is playing a role how to replace viral culture as diagnostic procedure of choice for establish enteroviral infection. And MRI in general may be normal. And differential diagnosis of viral meningoencephalitis is very wide. Could be other CNS infection, enteric encephalopathy, raised cerebral malaria, vascular abscess, and metabolic. Treatment, it's mainly supportive, except if herpes simplex virus is suspect, the treatment will be acyclovir. HSV, one most common cause of fetal encephalitis, count of 10%, overall 90% in adult. HSV, 2 more commonly isolated in monophasic or recurrent meningitis and congenitally acquired neonatal HSV meningoencephalitis. Symptom signs, 90% fever, 80% headache, 70% deterioration level of conscious. It's very important, this one percentage change up to 80%, which means there is encephalitis. Seizure, 67%, memory disturbance up to 45%, motor deficit up to 40%, aphasia, and olfactory hallucination. Regarding CSF, increased opening pressure, normal glucose, moderate elevated in protein, lymphocytic predominant, and thus xanthochromia and red cell may occur, culture negative up to 95, so need to send PCR. And in MRI, in herpes simplex encephalitis, temporal or orbitofrontal cortex enhancement. And in most other acute viral encephalitis, neuroimaging findings are non-specific. Brain MRI and CT serve to exclude brain abscess, subdural empyema, cranial extradural abscessing, or septic vena thrombosis. This is a picture of frontal enhancement. And EEG diffuse slowing, focal abnormality in the temporal region up to 70% with positive PCR. Indication of brain biopsy is very rare. In atypical case with poor response to treatment, finding we will see hemorrhagic necrosis, HSV antigen in infected neurons, acidophilic intranuclear inclusion. Treatment is immediately acyclovir up to 21 days, additional of steroids suggesting no obvious harm and some benefit. Mortality rate in untreated case up to 70%, with reduced up to 20% with treatment. Morbidity remain high. Only 37% of all patients with PCR proven and treated with acyclovir serve with no or mild residual deficit. Clinical relapse can occur and more often in kids. If there is suspected or approved resistant strain of acyclovir, maybe use alternative antiviral, or if there is allergic. Some clinical peers for bacterial and viral meningitis. 95% of patients with meningitis have more than 2 signs. Encephalitis results in depressed mental state. Immunocompromised and neonate can present atypically with unusual pathogen. Bacterial meningitis and herpes encephalitis has a specific treatment that improve outcome when treated quickly. Culture must be taken before antibiotic and also LB. Head CT should be obtained before LB when certain symptoms and signs are present, and empirical treatment, as I mentioned, to cover the most common pathogen, and steroids should be started. Just for refreshment, this is a male patient, young, come with symptom signs of meningitis and antimeningeal treatment start. And then the CSF culture grow Mesira. What medication should be continued? As I mentioned before, Mesira is highly sensitive to beta-lactam, so ceftriaxone alone is enough. No need to continue other medication. Other patient has liver transplant on immunosuppressive treatment for long period and came with symptom signs of meningitis and CT shown notable invasion to sinus cavities. And lumbar puncture cell count 10 with mainly lymphocytic RBCs 1, glucose low, protein elevated. What is the highly suggestive organism behind this? In immunocompromised patient with this clue in the CT invasion of sinus cavity, most likely is fungal meningoencephalitis. Cerebral malaria is very important. I will not go through it. Thank for Dr. Abdul Muin, his detail about malaria. Just keep in mind it's a serious condition and need to take it seriously. Few words about brain abscessing is there is a risk factor if there is a head trauma, local extension from mastoid otitis, sinusitis, meningitis, complication of meningitis or partially treated meningitis. Etiology, we need to think about anaerobes and staph aureus. Clinical feature, it will be fever, headache, vomiting, focal deficit, and increased intracranial pressure. Diagnosis by CT mainly, and treatment, we need IV antibiotic and surgical drainage. This is some picture about brain abscessing. Last and not least, I will talk about the last two conditions, mainly in immunocompromised patients, especially in age-defining illness. As we are in HIV center, we face those patients. So CNS toxoplasmosis is in infected HIV is usually complicated in the late phase when the CD4 is less than 100. And it will see in the CT ring in MRI ring enhancement, and there is treatment especially for treating toxoplasmosis, and then secondary prophylaxis after treatment, and there is primary prophylaxis when the CD4 is less to 100. Second condition, cryptococcal meningitis, also common in immunocompromised patient, is defined illness, and is very serious, and most common organism Cryptococcus neoformis and Gatti. Just a hint, Gatti can be affected healthy people. And there is a antifungal medication for this for prolonged period, and need following with CSF examination. And there can be screening and prevention by Cryptococcus antigen in the blood for those high-risk patients. Thank you. I know the topic is heavy, but I hope to highlight it to the most common CNS infection.
And vascular surgery and endovascular surgery.
Thank you.
خلاص كده ما يحتاج هذا passing. It's a pleasure to be with you today, and I would thank the organizing committee for this invitation to present with you today one of the acute disease during Hajj time. I'm going to talk about acute lymph ischemia. It's one of the common disease during Hajj time because for 3 reasons. Most of our patients or pilgrims is elderly, and they have a lot of cardiac disease, which is one of the reasons for acute lymph ischemia. The other issue also during Hajj this year will be in the summertime, so it will be a lot hot, and that lead to dehydration, and this also lead to acute lymph ischemia. The third reason also, the female patient, when they perform the Hajj and they want to avoid the menses, they are using the contraceptives, which is also one of the causes of the acute lymph ischemia. So going to definition first, it's acute lymph ischemia is sudden decrease in lymph perfusion that threaten the limbs viability. We consider it acute when it's within 2 weeks of the onset. It's okay. Fine. It's okay. I can. No, thank you. So the acute lymph ischemia, it's a surgical emergency with significant morbidity and mortality. The morbidity reaches to 30%, and the mortality reaches to 20%. And the incidence is 15 per and 3 per 100,000 for upper limbs and lower limbs, respectively. The etiology for that is mainly arterial embolism and thrombosis. Arterial embolism considered about 80%, thrombosis 10%, in addition to other reasons like trauma or iatrogenic. The embolism causes for the arterial and ventricular arrhythmias, paradoxical when patients have a congenital heart disease with the arterial ventricular shunts, endocarditis with the cardiac tumors also, non-cardiac reasons like atherosclerosis and aortic neurothrombi. In details, the thrombosis also is atherosclerotic obstructions, hypercoagulable stays with the patient with the vasospasm and aortic arterial dissection or bypass grafts. The presentation of the patient usually depend on the degree of the obstruction. Suppose patient have a partial obstruction, that will be mild presentation. When total occlusion, that will be severe presentation. Again, site of occlusion depend. The site of occlusion is very important when presented to distal artery. It will be threatened presentation, or major fissure like aorta. It will be also major presentation or catastrophic to the patient. Again, the affected tissue is important for us because some tissues it doesn't tolerate a long time of ischemia or warm ischemia, like the brain within 5 minutes, renal tissues with 15 minutes will get infarction, but skin and musculoskeletal, it take up to 6 hours or more. The presence of collaterals is important. It may survive the limbs, and it make the viability more for these patients. Acute lymph ischemia affecting the tissue, as I mentioned, the nerve tissues usually affected early, within 6 hours affected, and the muscle or musculoskeletals usually take more than 6 hours. One of the important issues with acute lymph ischemia management or presentation is the Ribofusion syndromes. They can present with a compartment syndrome, either early presentation or post-perfusion of the limbs, rhabdomyolysis due to tuberous necrosis, the cardiac arrhythmias. The cardiac arrhythmias usually post-perfusion because of the toxins and electrolyte imbalance, usually post-perfusion. Then the last presentation with the DIC. The physical finding here, we're talking about usually about 6 P's. Talking about pain, and the pain usually early presented severe pain or may disappear with the time when the nerve and sensory and mental motor lost. Pulseless, you cannot feel the distal pulse, distal to the occlusion, pallors, and paralysis and paresthesia. Classification of acute limb ischemia according to Rutherford classification. We are talking about 3 grades, 1 and 2 and 3. 1 usually is a viable limb still, and we have no effect in motor and sensory with no palpable pulse distal to the occlusion. And this stage usually is a mild, there is a window for investigation of this patient and is still viable limbs. Second stage is the threatened stage. Usually we classify to A and B, and the main difference between them is the motor and sensory loss. Usually in 2A, still there is a motor, and we lost or affected the sensory, but in B, it's a more threatened, and they have loss of motor and sensory with no audible signal distally. And this patient should be managed immediately. The last stage is irreversible, and this is patient with dead or paralyzed limb, and the option of treatment here is limited. Usually they will end by amputation. To investigate acute limb ischemia, we start usually with the non-invasive investigation or like ultrasound. It detects the level of the obstruction. CT scan also showing the level of obstruction and the runoff distal to the obstruction. Angiography here is invasive and usually use it when we are going to plan the patient for endovascular intervention. Talking about the management here, usually the initial management here to anticoagulate this patient immediately as soon as possible. So we'll start by heparinization of this patient, and usually using unfractionated heparin just to, and the aim of heparinization in this stage just to prevent propagation of the thrombus. Other supportive treatment, we have to supply the patient with oxygen to improve the skin perfusion and rehydrate the patient, and full screening for blood screen to look for thrombophilia and knee patient analgesia in early stage, but in the late stage usually it becomes paralyzed and the management of acute limb ischemia, either open or endovascular management. And the endovascular management, we have many options, including catheter-directed thrombolysis or pharmacomechanical thrombectomy. In the catheter-directed thrombectomy, usually we are using the catheters, percutaneous insertion to the area of the obstruction, and then infuse thrombolysis and keep the patient in ICU for 24 to 36 hours, and bring the patient again to the angio suite and make a diagnostic, looking for the prognosis of the patient. If we have good runoff or outflow, then we can stop the thrombolysis and keep him in heparin infusion. The other mechanism is mechanical thrombectomy, and this usually using the angiojet or Bembra. And here also we access the patient through percutaneously to the area of obstruction and infuse thrombolysis first, wait for the 10 to 15 minutes, and after that we can use aspiration technique with the angiojet. When we get a good release or dissolve of the thrombus, then we can manage the patient and looking for if there is any stenosis or dissection, then we can make angioplasty and stenting. We usually with mechanical thrombectomy are using the thrombolysis, and there is many absolute contraindication for thrombolysis. For example, absolute contraindication involving active bleeding disorder, GI bleeding within 10 days, cerebrovascular events within 6 months, intracranial or spiral surgery within 3 months, head injury. There is another relative contraindication, including major surgery, hypertension, cardiovascular CPR, or percutaneous non-compressible vessels. Many factors affecting the result or high success rate. This is usually recent graft occlusion. Within 2 weeks, we have high success rate to recanalize the graft and making thrombectomy either mechanical or surgical. guide wire, if passing the lesion, that we are lucky to proceed and make thrombolysis, or graft patency within 1 year, that give us also good indicators that this patient will be successfully thrombectomy. And presence of a treatable lesion, when we pass the wire or get stenosis or occlusion, then we can make a balloon angioplasty or stenting. The other factors with poor outcomes, when this patient have a diabetes or smokers, or they have synthetic grafts. The other option is surgical treatment. Usually we are using a balloon catheter thrombectomy, what we call it Fogarty catheters, or bypass procedure for a patient with stenosis or total occlusion. Then we bypass it with native or synthetic graft. Other option is endarterectomy for the with open patch angioplasty. The last option is hybrid, using both endovascular and open surgery. Here, the Fogarty, we use it for open thrombectomy or embolectomy. And usually what we do is open the vessels that accessible for us. Then we make proximal and distal control. After that, we pass the Fogarty catheters and extract the thrombus. After we have good inflow and outflow and two pass of clear pass, then we close the arteriotomy in transverse manners. Here, the procedure, we do the proximal and distal control, extraction of the thrombus, and closure transverse. Other option, as mentioned, if patient have total occlusion or severe stenosis, then we bypass this region using either veins or synthetic grafts. The last option is endarterectomy. We open over the stenotic area and remove the atheroma. This is the hyperdoar. We use it usually for combined open and endovascular. We are lucky in our hospital that we have it, alhamdulillah. And we used to use it for all the cases nowadays. Just in conclusion of this session, that acute limb ischemia is one of the surgical emergency carrying high mortality and morbidity, 20 to 30%, and it's still treatable if diagnosed early with good outcome. Thank you.
I welcome all of you in our topic about diabetes and Hajj. We are going to talk about why diabetes and Hajj, okay, and diabetes risk stratification prior to Hajj, common diabetic emergencies, and recent recommendations. Hajj is one of the 5 pillars of Islam, considering 8.8 global prevalence of diabetes, coupled with the number of Muslims performing Hajj around 2.5 million. It could be estimated that Muslims with diabetes performing Hajj might exceed 200,000. So during Hajj diet, the amount of fluid and physical activity might be altered significantly. Most Muslims with diabetes prefer to do Hajj duty, and this may cause major medical challenges for Muslims with diabetes and their healthcare providers. So it's very important for the healthcare providers to be aware of the possible risk that could happen during Hajj. So we are mainly facing what is called killer triad. They are not limited to, but mainly it's hypoglycemia, foot injuries, and infection. And this is from the literature review. I think for me, we will add also hyperglycemic emergencies, including DKA and HHS. Risk stratification, medical adjustment, proper clinical assessment, and education before Hajj are crucial, and even during Hajj. So here are some of the statistics. Regarding diabetes admission, there were 31.9% of diabetes were admitted, 26 of them were new, and around 74 known. Regarding diabetes status, around 77% had poor control, only 55% received diabetes education prior to Hajj. Regarding monitoring, 37% they do SMPG. What we meant by SMPG is self-monitoring of their blood glucose, and around 60% stopped their medication due to just misunderstanding or some wrong religious belief. Here are the risk stratification that should be done to any Haji patient coming with diabetes. They are classifying them to low risk, moderate, high, and very high risk. Low risk, basically, it's a patient with a good control of their diabetes, no history of hypoglycemia. He is on a lifestyle intervention or on medication that has a low risk of hypoglycemia, and there is no acute or chronic micro or macrovascular complication known for that patient. And he is a self-care of himself. That patient is can do or perform Hajj safely. Moderate risk, those with 7 to 9% A1C, that is fair control, no history of severe hypoglycemia, patient also on lifestyle intervention and medication that have a low risk of hypoglycemia, but he might be also on some medication like sulfonylurea or insulin that might cause hypoglycemia. He might having a foot ulcer, a remote past, a chronic micro or macrovascular complication, but a stable one. And this also Haji patient under this classification can also or might perform Hajj safely. High and very high risk, they all most likely the same. Those with a poor control, severe hypoglycemia or recurrent hypoglycemia, those on a medication that has a high risk of hypoglycemia, like ilobutamide, one of the sulfonylureas, or on insulin regimen. Those with a recent active episode of foot ulcer, they have a recent or acute exacerbation of micro or macrovascular complication, or a patient having chronic kidney disease with dialysis or recent MI. Those are considered high risk and they should postpone their Hajj performance. But of course, most of them, they are coming to Hajj. This stratification was based mainly on an expert opinion and an evidence-based trial should be done. I will go through some common health risks and emergencies that happen to a diabetic patient, like hyperglycemia, including diabetic ketoacidosis or hyperosmolar hyperglycemic state, hypoglycemia, foot injury infections. Those are the most specific one for diabetes. There are other non-specific like infections, cardiovascular, renal emergencies, eye emergencies, heat exhaustion and heat stroke, dehydration. I will go through the three main categories for diabetes. Regarding hyperglycemic emergency, in a study, there were 18 episodes of DKA admitted to Mecca hospitals during Hajj. Uncontrolled blood glucose was the main precipitating factors in almost 94% of the cases, with a mortality around 5.6%. Concomitant illnesses and inadequate use of insulin and oral antidiabetic agents precipitated diabetes complications such as ketoacidosis and HHS. And in another study, looked at cases of DKA admitted to one of the Medina hospitals. It was found that respiratory infections could significantly precipitate hyperglycemic emergency. So patient might present only with hyperglycemia. So to avoid that, in our emergencies or even in the clinic triage, we might correct his hyperglycemia and give them just tips to avoid getting that hyperglycemia, like drinking a lot of water, taking his insulin as prescribed, and immediate medical help if there is any signs or symptoms of ketosis. Some type 2 diabetes, even if they are on oral medication, they might take insulin on temporary basis in acute illnesses. Okay, what is DKA? I will go through DKA now. It's a biochemical diagnosis. We should have all these three triad for DKA: hyperglycemia, ketonemia, and metabolic acidosis. If one of these are missing, so the DKA diagnosis is questionable. Symptoms and signs: thirst, polyuria, nocturia, nausea, vomiting, abdominal pain, physical finding like tachycardia, dehydration, hypotension. If we go through all this, we see that the DKA symptoms and signs are non-specific. It could happen to any patient. Because of that, it has a biochemical definition, not depending on the symptoms or signs. Precipitating factor: infection in around 40% of the cases, non-compliance to treatment, newly diagnosed MI, increased carb content, and other causes like stress, pregnancy, medication related. Investigation include, there are three bedsides, we call it investigation, measuring the capillary blood glucose, measuring the blood ketones available, if not ketone in urine, and venous blood glucose. After that, we can do just CBC, venous blood glucose, renal function test, electrolyte, A1C, if not done within the last 3 months, septic screen and chest radiograph as needed, and lactate, finally ECG also as indicated. Okay, the severity criteria. This is what is the indication for ICU admission for such patient. We have clinical and lab indication. Clinical indication include a Glasgow Coma score less than 12, oxygen saturation less than 92, systolic PP below 90, pulse over 100, or bradycardia less than 60, oliguria, anuria, any organ failure, pregnancy, or a mixed type between DKA and HHS. Lab include blood ketones over 6, bicarb level below 5, or pH below 7.1, hypokalemia on admission, an iron gap above 16, or creatinine more than 200. So these are the outline management for DKA. After confirming the diagnosis, going through your ABC, putting a 2 large IV cannula and resuscitated with a bolus of fluid. We have to calculate the IV fluid according to the patient weight is 100 ml per kg in 24 hours. And IV KCl is according to the potassium level. And then IV insulin as a fixed dose, and we will go through that through the next algorithm. Continue the long-acting insulin. So if the patient is getting out of DKA, it's easy to transition him from IV to the subcut insulin. IV antibiotic as indicated, stress ulcer prophylaxis, DPT prophylaxis, intensive monitoring, and look for the etiology. So this is the algorithm based on ADA guidelines. First is IV fluid, determine the hydration status, if it's severe hypovolemia, mild, or cardiogenic shock. And then evaluate the corrected after giving the patient bolus and resuscitated, and he's hemodynamically stable. Next is to look for the corrected serum sodium and decide whether to continue on normal saline or high normal saline. Next is the potassium before the insulin. So after establishing adequate renal function with the urine output around 50 ml per hour, you have to look for the potassium level. If it's less than 3.3 or more than 5.2 or between 3.3 and 5.2. If it's less than 3.3, we have to hold on insulin or hold on if any bicarb infusion was indicated at that time, because both of them will cause hypokalemia and further hypokalemia. So hold on insulin and resuscitate the patient and give KCl until the potassium level is more than 3.3. After that, we can start the insulin. If it is more than 5.2, we don't give potassium, just monitor it every 2 hours. Between 3.3 and 5.2, we can just give the maintenance to keep it in the normal or the desired or target range. Regarding regular insulin, we have actually 2 ways to start insulin for that patient. Either give him a bolus 0.1 per kg and then give it fixed infusion 0.1, or immediately just calculated 0.14 unit per kg and start your continuous insulin infusion. and we will continue that till the blood glucose is less than 250. At that time, we can just decrease it 50% and add dextrose to the IV fluid. So how we know this patient is out of TKA if two of the following was reached: blood ketones less than 0.6 millimole, normal anion gap, pH more than 7.3, or bicarb more than 15. So DKA versus HHS, what is the difference between them? Is that HS, hyperosmolar hyperglycemic state, it has a profound or marked dehydration, high or marked elevation in the blood glucose, no acidosis and no ketosis, unless it is a mixed type. And there is also difference in the clinical feature. Usually the patient with HS, mainly they are type 2 diabetes, elderly, they come with altered mental status. Regarding its management, it's according to the ADA, the same management as DKA, and sometimes patient with HHS, just with simple IV fluid resuscitation, they can get out of the HHS easily before even the insulin is given. Next is hypoglycemic emergency. It's one of the major concerns during Hajj because of the efforts and the prolonged walking. One of the statistics is using of higher doses of soluble insulin twice daily without the intermediate may cause hypoglycemia derived from the physical activity or skipped meals. During Hajj, 2.4% of them reported a random blood glucose less than 4 millimole, that is less than 70. So basically, what is the management of hypoglycemia? If the patient was found to have a blood glucose level less than 70%, we will see his conscious level. If he is conscious and alert, we can follow the rule of 15, where we can ask the patient just to administer and eat a 15 gram or drink any juices, a 15 gram of glucose, and we will check capillary blood glucose every 15 minutes. And we will repeat that until we get the blood glucose above 70. At that time, we can ask the patient just to eat a mixed meal. If the patient is unconscious, we have two ways of managing it, either to administer glucagon or to administer dextrose D50 by slow IV push over 1 to 3 minutes. And again, we can repeat that till we get the blood glucose above 70. Some of the foot emergencies during Hajj in 2003, 2004, diabetic foot lesions were the common causes of admission, around 16.3. And the most commonly observed injuries were blisters in around 34% and erythema in around 25%. Also, many of the participants with diabetes had calcity. So prevention is better than the cure. We will, if any diabetic patient pass by us during the clinic triage or during the emergency, we have to educate them about the diabetic foot care. I will go through with medication adjustment. Medication adjustment for such a diabetic patient during Hajj is that metformin, alpha-glucosidase inhibitors, thiazolidine, all they have low hypoglycemic risk, and patients on those medications, we are not afraid to get hypoglycemia. But sulfonylurea is a high risk, has a high risk of hypoglycemia. It should be adjusted during Hajj. Other medication like DPP4, GLP-1, SGLT2, they all have low hypoglycemic risk, even if it was in a combination with other medication like metformin or insulin. SGLT2, it's a novel and approved drugs for the treatment of type 2 diabetes. The decreased rate of hypoglycemia make SGLT2 is a good choice, but it has another issue, which is volume contraction and dehydration. And because of that, RCT are needed to test its safety during Hajj. Okay. Insulin treatment, it's linked to an increased risk of hypoglycemia, and the dose should be adjusted during Hajj, either for type 1 or type 2 diabetes. The analogs are also superior to the human insulin formulation. Insulin pump is also more flexible with reducing the risk of hypoglycemia, but also in our hot weather, its use is also questionable and need more RCTs or studies upon that. So just simply, any diabetic patient can be managed during Hajj, before, during, and even after Hajj, to prevent having such complications. So just 1 to 2 months before Hajj, the diabetic patient should attend a clinic for education. There should be a prepared checklist for mandatory requirement, complete the recommended vaccination, do the proper medication adjustment, and keep their medication in a cool pack to store the insulin, the glucometer, and the ketone kits. And during Hajj, always carry some carbs, carry your glucagon injections, drink at least 3 liters of water daily. The Hajj patient should be educated to check their blood glucose regularly and adjust their insulin. If the Hajj patient is intended to walk a distance, insulin share can be decreased up to 20%. Sulfonylurea medication can be decreased up to 50%, sorry. And after Hajj, there will be a follow-up consideration. Hajj patient should complete a biochemical investigation and foot exam, and also a written exam. And those should be readjusted again after complying with the reduced activity. This is a sample of the checklist that the Hajj patient should carry on and check whether he did all the preparation for Hajj, either before or during. So as a conclusion, diabetes is a very challenging health problem, and it's a poor prognostic sign. A poor prognostic problem for many of the conditions was in our topics of Hajj season. Persons with diabetes should have a clinic visit 1 to 2 months prior to Hajj. Medication adjustment and 6-day management rules are considered. Education should be including pre, during, and after Hajj, just to prevent the severe hypoglycemia, hyperglycemia, or food complication. Thank you very much. Shukran.
The question is regarding what is the role of routine sodium bicarbonate.
Sodium bicarbonate, it's not a routine. There is an indication for sodium bicarbonate management is the pH than 6.9, or there is severe or marked hyperkalemia and concomitant with PKA. But it should be done in under ICU. Yes, because it was one of the side effects. Yes. Yes. Again, it's not a routine. We can add magnesium if there is a resistant hypokalemia with a concomitant hypomagnesemia. So if we can replace the magnesium immediately, the potassium will be corrected in concomitant with the magnesium. Thank you.
What is the role of Ribofusion in the patient who have vasculitis?
Yeah, there's no rule. Ribofusion would be chemo that could offer scheme. Vasculitis was the fault of and for the patient to have vasculitis, they usually chronic
they rarely have acute presentation. Ribofusion is not different. When the patient came delayed acute ischemia, they have a compartment or paralysis, or after the perfusion of the limbs. And the perfusion of the limbs is very high Ribofusion Syndrome. Ribofusion Syndrome, including compartment, paralysis, and myocardial infarction, arrhythmias, or the accident.
And give a no rule for any procedure, patients in first one.
No, usually the last slide, chronic disease, they usually rarely present an active state.
Next question for the forum. What is the role of smallpox vaccination, protection against smallpox?
So if protection, the smallpox vaccine give around 85% protection against the monkeypox.
The question is, there is any recommendation if smallpox has vaccination to protect against smallpox disease?
At the current time, according to WHO and the CDC and the Ministry of Health, is not recommended. Just we will concentrate on the early detection of the case and aiding population and active surveillance with contact tracing with all the major infection control.
The last question is for Nishwa.
Actually, the coverage for meningococcal vaccine is recommended now for acute Hajj season, but till now there is no knowledge about the just the use for one recommended for the last and the more.
This is the list for well, this will include our own schedule. Inshallah, we'll start with teaching our method. Teaching is very by Dr. Nahar al-Azhari. It's going to be diagnostic early consultant and non-vascular interventions. And we will complete the more one of the extra consultant with our North specific hospital. Inshallah, see you inshallah on the other side. Thank you.
So, Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Maher, for presenting me. It's my pleasure to be a speaker in Hajj medical conference in the Noor Hospital in our holy Mecca. As all of us know that the trauma during Hajj is very common. So yesterday, Dr. Kamal, he presented about the traumatic brain injury. And today I will gonna review the pre-hospital and emergency department management, and then I will focus on ICU management of the TBI according to the emergency neurological life support algorithm. So our objective to know how to diagnose and classify the severity of the traumatic brain injury, to explain the rationale for prevention and management of secondary injury, and the last to list the step of each stage of ANLS TBI management algorithm. So first, the pathophysiology. After patients have external force, either through the motor vehicle accident, fall, or blunt injury, it will cause alteration in the brain function and brain pathology. And this will cause the primary injury. And then, as a consequence of primary injury, the secondary injury will occur. So our target to minimize or manage primary injury and prevent the secondary injury. So the primary injury usually occur following the TBI at the time of the impact. The focus of post-injury management is to prevent the worsening of primary injury and to mitigate the severity of the secondary injury. Okay. So the rationale for the prevention of the secondary injury usually begin immediately after the trauma and occur on both microscopic and macroscopic cellular level, and it is the major determinant of the clinical outcome. Okay, how the secondary injury occur? It's occurred due to impaired cerebral blood flow regulation, due to alternation in the brain metabolism, and upregulation of inflammatory mediator, oxidative stress, and vasospasm. At the end, it will cause brain edema and herniation and eventually brain death. So because of that, we want to prevent the secondary brain insult. Usually 50% of deaths from TBI occur in the first few hours after the trauma. The hypotension play a major role to increase mortality and morbidity. Hypotension means that systolic blood pressure less than 90. So our target more than this. Okay, it will increase the mortality and morbidity 34 to 75%. Hypoxemia also play a major role, like partial arterial oxygen pressure less than 60 will increase mortality and morbidity 34 to 59. Also, a metabolic disturbance like excitatory neurotransmitter release and free radical generation, it will play a role. Intracranial hypertension and seizure. Because of that, we will focus how to manage the intracranial pressure and seizure prophylaxis. So this is the heterogeneity of the traumatic brain injury. After external force happens to the patient will suffer either one or combined of these injuries: skull fracture, parenchymal injury, and vascular injury. In the parenchymal injury, we have contusion and axonal injury. And the contusion will have the highest risk for high ICP, high mortality, and high disability. Regarding the vascular lesion, we have extradural, subdural, traumatic subarachnoid, and petechia. Subdural have the highest risk of high ICP and mortality and disability. Okay, this is how epidural appear in the CT. It's look like lenticular shape. And this is the subdural appear. It's like a crescent shape. This is the interparenchymal hemorrhage or hematoma or contusion, which is have a high risk of mortality and disability. This is the subarachnoid, okay, with some minimal IVH. This is diffuse axonal injury. Sometimes in the CT, diffuse axonal, it will not appear, but it may appear in the MRI as scattered microhemorrhage. Okay. And at the end, this is, as you see, there is loss of white gray matter differentiation and loss of the gara and sulci because diffuse swelling and edema. This is the CT in the first day, and this is in the second day. As you see, the second day, the hemorrhage become more obvious. So because of that, the management should be start from the insult. Okay, so before starting the management, we have to do initial injury consideration. We have to ask about the mechanism of injury. Okay, we have to assess the Glasgow scale post-resuscitation before intubation and sedation. Why? Because it will give us the hint about the severity of traumatic brain injury. As all of us know, the GCS normally 15/15. But if the GCS drop from 15 to 13, it will cause mild TBI. And if the GCS 9 to 12, this is moderate. And if 8 and less, this is severe TBI. We have to do a neuro exam. We have to rule out other consideration of loss of consciousness, like hypovolemic shock, alcohol, toxin. So the early indicator for prognosis in the severe TBI, an estimated patient prognosis should be never the only factor. Instead, the prognosis is one of many factors that need to consider in the management of the TBI. This is the Marshall classifications for assess the favorable outcome at the discharge. If you see here, the diffuse injury with no visible intracranial pathology will have the most favorable outcome at the discharge, while in the diffuse injury with midline shift more than 5, it will have the poorest outcome at the discharge. Because of that, if you have patients with midline shift more than 5 millimeters, you have to consult urgent neurosurgery for intervention. This is the algorithm for from the emergency neurological life support (ENLS) for the TBI. It involves pre-hospital care, emergency department care, and ICU. In all of these stages, we have one goal: to prevent secondary insult. So in the pre-hospital, the paramedic should have care of the spine, motion restriction, and applying the collar. They should have do ABC to keep SP2 more than 90, because as we said, less than 90 it will increase morbidity and mortality. They should have to maintain systolic blood pressure 100 to 110. Okay, they should have obtained history for medication. What medication? Very important in TBI: anticoagulant, antiplatelet, because it will play role in hematoma expansion. So we have to ask about this and may need antidote. Also, alcohol history and drug abuse. We have to ask about the mechanism of injury, if there is any loss of consciousness during the insult, or trauma, or seizure, or amnesia. Of course, they have to do the UCS exam and pupil exam, because the pupil will do it in the pre-hospital, emergency, and ICU. It will tell us about the intracranial pressure. Avoid prophylactic hyperventilation. Our target CO2 35 to 40. While treat patients with brain herniation with a transient hyperventilation, CO2 30 to 35. Why we want to do hyperventilation? Because hyperventilation, it will cause vasoconstriction for the brain vessels, and then it will decrease the edema. But For the long period, it will cause ischemia and increase mortality. So we are using for transient till the neurosurgery take the action. Okay, so pre-hospital blood pressure treatment, hypertensive patient should be treated with isotonic saline. It means normal saline, no ringer lactate, no hypotonic, no D5, no albumin, because all increase mortality. So normal saline for station and trauma patients. Our target blood pressure in the adult is from the age from 15 to 49 and 70 and more. Our target from more than 110 systolic blood pressure. But between of this, 50 to 69-year-old, the target systolic blood pressure more than 100. This is the evidence base from the New England Journal of Medicine regarding albumin versus saline safe trial published in 2004, and it showed that albumin increased mortality. This is the impact of pre-hospital administration of ringer lactate versus saline. It's published in 2016. Also, ringer lactate increased mortality, so we have to avoid. In emergency department, regarding emergency department is a continuation of the pre-hospital management plus stabilization and resuscitation. After that, we'll do the GCS exam and the bugle and obtain CT. Okay, of course, we're gonna consult a neurosurgery, avoid the hypoxia, hypotension, fetal herniation, corrective coagulopathy. As we mentioned that coagulopathy, it's play major role for hematoma expansion, seizure prophylaxis, analgesia, and sedations. And avoid the steroid hypothermia. I will tell you about this in detail. So, avoid the hypertension and hypoxemia, maintain SpO2 90 and above by supplement of oxygen or endotracheal intubation, maintain pre-hospital blood pressure target, provide the hemostasis and isotonic fluid policy normal saline. This is in the ICU. This is the tires protocol for usually increased intracranial pressure. We have tier 0, tier 1, tier 2, and tier 3. Tier 0 usually not ICD dependent. It's basic neuro critical care management for any TBI. We have to admit the patient to the ICU to introduce endotracheal intubation and connect mechanical ventilation, to do the serial evaluation for the GCS and the pupil, and to keep head of bed elevated. Why? To decrease venous return, to increase venous return from the brain, so decrease the edema. Okay. Also, we want to minimize the metabolism of the brain and relax the brain by analgesia, sedation, target temperature, euthermic, no role for hypothermia, and avoid hyperthermia because it will increase metabolism and it will worsen the insult. Of course, we're going to start anti-seizure medication, keep the CBP cerebral perfusion pressure 60 and above, and hemoglobin to keep more than 70, and consult in neurosurgery. Okay. Then if a patient have sign of, after this tier 0, if patient still have sign and symptom of increased intracranial pressure, I will tell you about the sign and symptom of increased intracranial pressure, then we're gonna move to tier 1. Tier 1, appropriate sedation of the patient and analgesia, target CBB 60 to 70, and CO2 35 to 38, mannitol hypertonic saline as a dehydrating measure, and anti-seizure prophylaxis, and consider EEG and consult a neurosurgery for EPD. Okay, if the patient is still not improved, this is indicate that he have increased NCB and may patient develop herniation. We have to start transient hyperventilation targets to 32 to 35, and consider muscle paralysis and give fluids for increasing LMAP to decrease intracranial pressure and improve cerebral perfusion pressure. As all of us know, cerebral perfusion pressure means MAP minus intracranial pressure. Okay. At the end, if still patient deteriorate and not improve, then we'll move to the last tier, tier 3. This is include phenobarbital coma, craniotomy, and hypothermia. So this is the sign of symptom of increased intracranial pressure, dilated not reactive pupil, asymmetrical pupil, mean that the difference between the two pupil more than 1 millimeter. Motor exam demonstrate extensor or no response, mean M2, M1. And decline of the GCS more than 2 points and Cushing triad, which mean bradycardia, hypertension, and regular respiration. So the indication of the ICP monitoring, if patient have severe TBI with abnormal CT or with normal CT plus 2 or more of the following: age 40 or more, motor posturing and systolic blood pressure less than 90. In the moderate TBI, we have to do ICP monitoring if we have mass lesion, midline shift more than 5, and effaced cisterns or post-craniotomy. This is the wave of intracranial pressure. So we have the 3 waves. This is the normal one. We have B1, B2, B3. B1 is the longest one. Okay. So B1 indicates the arterial pulse. Okay. B2, this is for the cerebral compliance, and B3 for aortic valve closure and necrotic notch. You see here, this is the normal, and also this is the normal. But if a patient have to increase B2, this is mean that increase intracranial pressure and decrease compliance and risk of herniation. This is again, this is the normal waves. This is here, if you see, B2 start to be elevated and the compliance will decrease and intracranial pressure will increase. If B2 become taller than the B1, so here the compliances will be very, very poor and patients have increased intracranial pressure. Is it mandatory for any patient with TBI to do ICP monitoring? This is the trial published in 2012. It will answer us. For the patient with severe traumatic brain injury, care on focusing maintaining the intracranial pressure 20 or less. Why 20? Because if intracranial pressure more than 20, increased risk of herniation. Okay, so it's shown no superior to clinical examination and image. So not routinely we're going to use unless there is indication. So medical treatment for high ICP, I mentioned before regarding the mannitol. Mannitol is osmotic diuretic, so we have to avoid in the hypotensive patient. Our target serum osmolarity 320, and we have to start it just for 48 hours, not more than this, because it will cause a rebound edema. Okay, hypertonic saline, better to use in the hypotensive patient. Target sodium 145 to 155 degrees osmolarity, and then shifting of the fluid from parenchyma to intravascular. This is the indication for the surgery. Patient with TBI. A patient have subdural hematoma with thickening more than 10 or more than millimeter midline shift, or patient have any size but the GCS drop more than 2 and have asymmetrical or non-reactive pupil. So this is the indication in the subdural. In epidural, if the thickening more than 15 millimeter, yes, and or shifting more than 5 midline, or GCS less than 8. In the cerebral contusion, if there is shifting, in cerebellar, if there is brainstem compression and hydrocephalus, because you know the cerebral is very small space. Debris skull fracture also indications, sign of the CSF leak from the nose or the ear, and intracranial pressure refractory to the medical entire 3 we mentioned. We have to consider surgery. So regarding the trial and evidence for decompressive craniotomy in TBI, we have DICRA and rescue ICP. This is DICRA published in 2011 and show that in adults with severe diffuse traumatic brain injury and refractory intracranial hypertension, early bifrontotemporoparietal decompressive craniotomy will decrease the intracranial pressure and also will decrease the length of stay of ICU, but it will associate with unfavorable outcome. So no benefit, okay? This is the rescue ICB published in 2016 at 6 months. Decompressive craniotomy patient with TBI and refractory increased intracranial pressure. It will lower mortality and higher vegetative state, but in the severe disability. But in the moderate and mild, it will not affect. Okay. Coagulopathy, as we mentioned, coagulopathy, it will play a major role for hematoma expansion. So we have to consider transfusion of PCC, platelet, and FFP to start antidote. If you take the history from the relative and you know what anticoagulant or antiplatelet is on. Frequent monitoring of coagulation profile, fibrinogen, and platelet, and rule of tranexamic. Actually, this is the CRASH 3 that show that the role of tranexamic acid in TBI. Tranexamic, it will save 1 in 5 people who have died from the mild or moderate. So no role in the severe. Yes, mild, moderate, it will improve mortality. Seizure prophylaxis. We have to start for all patients with TBI seizure prophylaxis. We prefer Piriton because there is a trial about it. And it will be for just 7 days if there is no clinical EEG activity after that, so will DC. This is the evidence for seizure prophylaxis. Piriton, it's get beneficial or exert beneficial effect for reducing seizure during the first week, not more than 1 week, if there is no activity clinical or by the EEG. DBT prophylaxis, as all of us know that the TBI is associated with a high incidence of the DVT, and without prophylaxis, the incidence will be 54. With prophylaxis, mechanical, not chemical, the DVT will be 25. So all patients with TBI should start mechanical prophylaxis as soon as possible. Regarding chemical prophylaxis, will start after 48 hours to 72 hours if there is no CT deterioration. The steroid in the TBI, this is CRASH 1 trial, show that it will increase mortality for 2 weeks and 6 months, so contraindicated. This is the hypothermia that show no role in the TBI. Okay, so in summary, as the trauma is very common during the Hajj season, so we have to start management as soon as possible for the TBI to prevent the secondary insult, to start resuscitation with normal saline, avoid ringal lactate, albumin, hypotonic saline, contraindicated to start steroid because it will increase mortality. Thank you for listening.
Thank you, Dr. We will move to the next talk. This talk will be presented by the He's the head of the plastic surgery department, and he has the MRCS fellowship for College of Surgeons in Plastic Surgery. Please welcome Dr. Salim. Dr. Salim, please go. Thank you.
السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Maher. Thank you for organizing the committee, for giving me a chance for this to present. Alhamdulillah, this is unique for Makkah al-Mukarramah. It's a mercy of Allah Azza wa Jal for every year we have this Hajj. And mashallah, it's also unique for the Noor Hospital to present this Hajj symposium for years and years, mashallah. So just to give a talk about this, some pictures maybe it's not good, but this is very common. You will see the mechanism of trauma for chest trauma, either a severe car accident or falling from height. Thoracic trauma is the second leading cause of trauma, death after head injury. It can cause about 10-20% of all deaths, and many deaths can prevent, actually preventable if you tackle the patient the first. Huh? Huh? Oh, okay. Inshallah, we'll get rid of this mask. Right. Many deaths are preventable, actually. And if you tackle the patient the first second or few minutes, and fortunately, 80% of those patients required only to correct hypoxia and improve circulation and alleviate ventilatory obstruction. 15% only need surgical intervention. A lot of preventive strategy, of course. It's worldwide and countrywide. Now it's mandatory for seatbelt to wear it, and airbag as well. Sport training and protective equipment, and gun safety education. As usual, we heard yesterday from many presenters about the mechanism of, in general, trauma. It's a blunt injury, either deceleration or compression, or penetrating injury. And this is just a picture to show how the chest trauma can occur. From the steering wheel, you can predict from the history the fracture sternum or vertebra or rib fracture, or there is associated pneumothorax or hemothorax or diaphragm from this picture as well. So usually the chest trauma, it can lead to hypoxia. Why? Because there is sometimes pneumothorax or hemothorax compressed on the lung and cause ventilation perfusion mismatch and hypoxia and hypercapnia as well. And it leads also to acidosis from hypoperfusion. I don't want to go for detail for the hypoxia, but usually it is ventilation perfusion mismatch because of pneumothorax or massive hemothorax and abnormal pleural and airway relationship. At the same time, if there is any insult to the heart itself, it can cause the diminished cardiac output, and the patient becomes severely hypovolemic due to blood loss as well in the pleura as well. So the impairment of ventilatory efficiency because of chest cannot expand well, because of pain, because of air in the pleural space, asymmetrical movement of the chest, and bleeding inside the chest. All this cause diminished respiratory ventilation and affect the patient hypoxia and acidosis. Atelectasis, pulmonary contusion, respiratory tract disruption, can cause all this, can cause impairment of gas exchange. So how to manage? I think you heard from yesterday, in all trauma, you have to manage an ATLS protocol. Either there is a chest trauma, but you have to follow this. This is the safest way. You have to control A, airway, T, ALS protocol, airway, breathing, circulation, disability, and so forth. Airway, usually with C-spine. Most of the risk score, they forget about the C-spine. And this can cause disability if you don't take care about this C-spine. There is a special maneuver. We should not, we'll see we'll show you now one of the pictures here, how to deal with the C-spine in case of trauma. Free breathing, C circulation, D disabilities, and E exposure. This is a unique for all trauma patients. You have to do this to save the patient life. So the initial examination towards the chest or whatever is directed to the primary survey, ATLS protocol ABCDE. So airway obstruction, open pneumothorax, flail chest, tension pneumothorax, massive pneumothorax, and cardiac tamponade. This is the first 6 killers to the patient in a few minutes. If you don't recognize this by systematic approach ABC, you will miss it. And this can kill the patient in a few minutes. So this is 6 condition. You have to be aware of it immediately in the primary survey. So we'll go to airway ventilatory compromise, how to manage, secure the intact airway, protect jeopardized airway, and provide airway if none. Please all the time be aware of C-spine injury. If we don't mobilize C-spine in the right way, the patient will become paralyzed if he proceed to be alive, if he's going to be alive. This is a picture of the fracture C-spine. So all the time, please be aware of contraindication. Chin, lift, and jaw thrust to open the airway, to suck, to remove foreign bodies. It's a chin lift and jaw thrust. Suction, oral airway, and nasal airway. So please, you have to avoid this all the time. This, they call it head tilt and chin lift, because you don't know what's going on in the cervical spine. This is the jaw thrust technique, should be applied in a trauma patient. This is in non-trauma patient when you open the airway. But here to open the airway, you have to be careful. Use this technique, what they call the jaw thrust technique. So most of the common of the airway injuries, the laryngeal injury is rare. It's not very common from the airway as a whole. And patient presented with hoarseness voice, subcutaneous emphysema, and the examiner will feel the palpable fracture of the larynx. Treatment: this patient all need intubation, they are doing tracheostomy, and definitive treatment by surgical operation. Open pneumothorax. How can you diagnose open pneumothorax? There is open pneumothorax and closed pneumothorax. Open pneumothorax is the second cause of a lethal condition in case of chest trauma. It's by definition, it's a hole in the chest wall, allow air into the broad space. And the larger the hole, the more likely air will enter than through the trachea itself. If the trauma patient does not ventilate well with an open airway, look for the hole all the time. It may be subtle. Sometimes you cannot see it. So you have to examine the patient properly to see if there is any hole or not. This is the hole at the back of the patient. So you have to examine the back. 50% of patient examination at the back and 50% in front. So the open pneumothorax, how to assess? It's an opening the chest wall. Usually, when you ventilate, you will suck the airway. You will suck the air from outside. It's a negative pressure, but here it will create positive pressure. That's why the patient cannot ventilate and cannot maintain his saturation. Patient uses tachycardic, tachypneic, is in distress, and there is subcutaneous emphysema, decreased breath sound on the affected side. So, if you don't examine the back of the patient, this is the result. The cause of ventilation of the patient, severe hypoxia or non ventilation, this is because a big hole at the back of the patient and that's caused severe hypoxia to the patient, and probably will kill the patient in minutes if you don't treat it. The CT scan, it does show there is a hole in the chest wall communicating with the chest inside. So how to manage? Again, you have to do protocol of ATLS protocol of ABC. Okay, cover the chest opening with occlusive dressing, and you have to manage to give fluid and oxygen and the rest of the management. And this is how the way to close the hole is to call it 3-way. 1, 2, 3, and leave this open, because during inspiration will suck and there is no air will come from outside, but during expiration the air will come out. It's like a normal physiological breathing. And of course it has to be transferred and to the surgical repair. Tension pneumothorax, it's a very common cause of patient killing during trauma, chest trauma. Tension pneumothorax, it's either penetrating and blunt trauma. It can occur in both, actually. Morbidity and mortality depend on severe hypofiltration, immediate life-threatening if not managed early. How to assess? Patient is severely dysnic if he is conscious, severe dyspnea, restless, anxiety, agitated, decrease or even absent breath sound on the affected side. And this is will be worse if the patient is in shock, severely tachycardiac, weak pulse, hypotension, and low pulse pressure. During examination, you will feel or you see jugular venous distension. Okay, there is absent if patient severely hypovolemic, but this is very common. We see it, and there is hyperresonant percussion, subcutaneous emphysema, trachea shifted away from the injured side. And if you not treat the patient immediately, the patient will become really cyanosed. So you have to, this is very important sign. Immediately you have to treat the patient if you saw all these signs and symptoms of the patient. So how to manage? Again, A, B, C, D, E. Okay. Of course, you have to elevate this and give the patient the IV fluid, and to elevate this, decompress, you have to pass a needle, big needle, in the second intercostal space in mid-clavicular line, and recent recommendation like to put in the chest tube in the fourth intercostal space in mid-axillary line, just to decompress this, and the patient immediately will return back to a normal condition. So, tension pneumothorax, it's a clinical diagnosis. You should not diagnose tension pneumothorax based on the X-ray. If you wait for the X-ray to be taken, the patient will be killed. So, unfortunately, this X-ray taken, which is not true, of course, but anyhow, this is the big tension pneumothorax. If you cannot see the lung here and the mediastinum, all the mediastinum in the middle, he shifted to the normal side. There's another X-ray on opposite side, total collapsed lung and mediastinum shifted to the right side. So again, it's a clinical diagnosis. It's not an X-ray diagnosis. The other most common killer to the patient is the flail chest. What's the meaning by flail chest? When you see 2 or more adjacent rib fracture in 2 or more places, it's a producing free floating segment. You see here, it's close, it's fracture from here and there, as if you cut this piece. It's 1 or 2, you consider this a flail chest. Of course, it could be more, it can be. This is, what's the dangerous of this? Usually it's secondary to multiple trauma, most commonly in motor vehicle accidents. It results from fall and from assault. And this is very common also during Hajj. You will see fractured rib and flail chest. The mortality from flail chest may reach 40%, and especially if there is associated injuries. Mortality increase with advanced age, more than 7 or more ribs fracture, or there is associated injuries, or the patient is in shock, or if there is associated head injuries. See, this is flail segment, as if the segment separated from the whole ribs. What's the sequences? The patient will be respiratory failure, pulmonary confusion, which it causes hypoxia, and associated intrathoracic injury. And there is associated inadequate diaphragmatic movement to the chest. And in severe cases also, there is paradoxical movement, and this will interfere with the physiology of respiration and cause severe hypoxia, and the patient most of the time need to put him on mechanical ventilation. So the management again have to ATLS protocol, and the patient also might need to put him on ventilation and breathe pressure as well, and mechanically stabilize the chest wall by surgery if it's not responding to mechanical ventilation. The fourth common cause can kill the patient in a few minutes. It's a massive hemothorax. By definition, massive hemothorax, more than 1,500 mil blood loss inside the pleura. It comes from either systemic arteries or pulmonary vessel disruption. And here you will see flat neck veins. In tension pneumothorax, you will see distended neck veins. Patient will be in shock, of course, and you will examine him. There is no breathing sound and or percussion dullness. In tension pneumothorax, there is hyperresonance to differentiate between this and tension pneumothorax. So how to manage? Again, you have to follow the ATLS protocol. Establish the airway first, control high oxygen, and then patient should be under monitor and give IV fluid. And of course, you have to put a chest tube to measure how much it drains. More than 1,500 is an indication for surgery to correct the problem of this patient. So ultimately, he needs surgery, this patient. This is some of the X-rays. This from trauma. It's all massive hemothorax. It's all whitish. Normally, it looks like dark in color. And this CT scan, it showed completely collapsed lung with the massive hemothorax. This intraoperative finding. Another common cause of killer to the patient is pericardic tamponade. It's not very common, but it can occur, especially with this penetrating injury. Sometimes it's ignored, but this is directly towards the heart and can cause cardiac tamponade, pericardic tamponade. It's only need a small amount to cause this tamponade. The heart cannot function, cannot pump blood outside. It's more common with penetrating injury more than blunt injury. So usually there is a fluid inside the pericardium, but very minimal, about around 30 cc, and this is for lubrication and the others. The heart will be filled with the pericardium filled. Heart cannot function. Heart cannot pump blood outside, and the patient become severely hypotensive and decrease the blood pressure. So this is some of the signs: increase resistance hypotension, and there is no obvious bleeding. Where does it then come from? You have to look and consider the heart, especially from the mechanism of injury. There is no obvious bleeding from when you examine the chest, when you examine the abdomen, when you examine the pelvis. No obvious bleeding. Then you have to think about the heart condition. So this is the distended jugular vein, one of the manifestations of pericardic tamponade. Of course, to manage, secure the airway, give IV fluid, give oxygen, and if you practice, or the cardiologist can do pericardicentesis, that will be good, and the patient should be transferred immediately to trauma center for consideration. This is the way how to aspirate the blood from the pericardium and to elevate and this is all different site to parasternally or external part. Some of the intraoperative finding. Now we'll go to the other causes, which is potential cause of lethal condition. We mentioned 6 of them now. Now we have to go for another 4 or 5 or 6 condition again for pulmonary contusion, myocardial contusion, aortic disruption, traumatic diaphragmatic hernia, tracheobronchial disruption, and esophageal disruption. Pulmonary contusion, you'll see the X-ray here. The problem with the pulmonary contusion, it affects respiration and affects oxygenation to the patient. It causes VQ mismatch to the patient. So patient be tachypneic, tachycardic, some patient with severe contusion, the patient develop hemoptysis and cyanosis as well. So the management should be supportive and be careful about the fluid resuscitation. Should not be aggressive, otherwise it causes bleeding from the lung itself. And of course, we transfer the patient to trauma center. This is how it looks like. It's white color, not normal black. This white color. This lung, all lung confusion, and affect, of course, respiration to the patient. This lower lobe here. So the cardiovascular trauma, any patient with significant blunt or penetrating trauma to the chest has heart or great vessel injury till proof otherwise. Myocardial confusion is the most common from blunt injury, not penetrating, usually due to steering wheel injury, and it is a significant cause of morbidity and mortality in the blunt trauma. And this is usually the mechanism of trauma. How to assess the patient have arrhythmias by all means, chest pain, angina-like pain, pericardial friction rub when you hear the chest, and this is very common when you see all this contusion in front. You have to consider about myocardial contusion. So a lot of ECG changes of arrhythmias, myocardial, to manage again ABC, fluid, and consider monitoring, and consider immediate transfer of the patient to the trauma center. This is intraoperative how it looks like. Traumatic aortic disruption, again, this is very dangerous and can kill the patient in a few minutes, and usually from motor vehicle accident, fall from height, or gunshot as well. It's a mechanism of injury again. Unfortunately, 85 will die at the scene. 10 to 15% survive in hospital. Among those, also one third will die in 6 hours, one third die in 24 hours, and the rest will die in 3 days. How to assess? It's severe pain, respiratory distress, asymmetrical blood pressure when you measure both hands blood pressure, and decreased femoral pulse or absent femoral pulses, and patient feel dysphagia. When you see wide mediastinum, it's not normal, this one. Or usually the mediastinum about 1 centimeter, for example. But when you see wide mediastinum like this, you have to think about traumatic aortic disruption. This is X-ray, and this CT scan. It shows wideness here. It's very wide mediastinum here. So how to manage? Again, ABC protocol, IV fluid, and nowadays the vascular colleague, they are doing a stent, and they stenting the patient most of the time, and it's successful. The other condition can kill the patient in after a few hours. Traumatic diaphragmatic rupture, usually due to blunt trauma or pericardial trauma. Also, it's life-threatening, associated with other injury most of the time, and it's usually compression on the abdomen, either lateral condition or antero-posterior compression or anterior compression can cause rupture of diaphragm, and usually left side, because right side there is a presence of liver, so most common on the left side. So how they assess? To assess decreased breath sound, and you will hear gurgle sound or dystonia sound inside the chest. Dullness in percussion, patient respiratory distress, and there is empty abdomen, for example. This is abnormal, bizarre picture. Looks like a stomach inside the chest. And this is CT scan, it showed us. And this is another picture. It shows bowel inside the chest. And this is barium also done. It showed inside the chest. This is some operative picture. It shows diaphragmatic hole here and rupture. So again, to manage, follow the protocol of ATLS with fluid and everything. So suspect intra-abdominal trauma with any injury below the fourth space. Suspect intrathoracic trauma with any abdominal injury below the umbilicus. Esophageal injury is not very common actually, And usually you have to suspect that there is a penetrating wound in paravertebra, and usually on the posterior at the back of the patient. And you have to have high suspicious for this injury. And usually the patient will have pain and tenderness with the subcutaneous emphysema, and some also, there is some pneumomediastinum, air inside the mediastinum as well. So the management again of protocol, ATLS protocol, I've included the transfer the patient to trauma center. Tracheobronchial rupture is not common, but it can occur. And with the blunt injury, most of the time, it's a majority near the carina. And again, it's like diaphragmatic injury. We need a pressure, and it can cause tension pneumothorax, and patient can kill in a few hours. And this is the cut of the right main bronchus from the mechanism of the trauma itself. And usually patient become dyspneic, tachypneic, and sometimes hemoptysis, bright blood, and signs of tension pneumothorax. You put a chest tube, still there is a pneumothorax. You put another chest tube, still there is a pneumothorax. Then you have to think about tracheobronchial injury. So some pitfall to avoid during chest trauma: elderly do not relate relatively minor chest injury, anticipated progression to acute respiratory insufficiency. Children may sustain significant thoracic injury who, without evidence of thoracic skeletal trauma, maintain usually all the time, and chest injury maintain a high risk index of suspicious. So in summary, chest injury are common in the multiple injured patient. Use ABCD approach protocol, airway control, C-spine stabilization, tension pneumothorax, clinically diagnosed, should be treated immediately with needle thoracostomy followed by ICT insertion. Look for the whole opening of the chest for open pneumothorax. Flail chest, consider intubation if patient develop respiratory failure. Massive hemothorax, consider operative management. And cardiac tamponade shows similar signs and symptoms to tension pneumothorax except muffled heart sound. Thank you very much.
Any questions regarding the position of patient?
Three-way the victor. So if you look at this view, the idea of three-way adhesive closes there. You have to put it in a normal way. Yeah.
The second question regarding the teaching of us. We have a patient in the radiology department doing X-ray or CT scan, and we found itching in the thorax. You prefer to insert on any one of the medical field, or it's better to leave
No, anybody practicing, even here, either resident or specialist ER or thoracic, not necessarily thoracic, or general surgery team, for example, just to decompress. That's the most important thing. Patient will come open and then followed by ICT. But you have to decompress it first, which is very important and very quick.
Question regarding the hemoglobin part. And the one number two, how do we the amount of
it's not very common, but to treat it depends on clinical assessment. If the patient is full of hypertension or severe hypoxic, it makes difference. Like a immune disorder from air itself. So usually treat it with no need to do anything, and it goes and absorbs slowly by time.
Like yesterday, lunch will be provided as common food. And please, for attendance, for entry, you have to hold the ID card and install first to enter the swimming pool, okay? And see you at 1 p.m. sharp. Thank you for your attendance.
قالوا بطارية جديدة موجود. ايوه. الله يسلمك تسلم يا صالح.
Yeah, I will love so please. انتوا كنتوا شغالين عليه ولا كيفيته؟
لا كنت شغال هو في سليب مود. لا من
الراعي دوبه كان في القاعة. لما عدلت سلايدات كان شغال. الله.
عايشة الدكتور؟
ايوه. طيب السلام عليكم. يعطيكم العافية وجزاكم الله بالخير. We are going to resume our program and we have to continue our course. And we have Dr. Ruzan Rahman. She will talk about the implication in Hajj. Dr. Ruzan, she is certified with master degree in clinical pharmacology and toxicology from Umar University. And he is the supervisor of continuous education and training as well as
أقدر أبعد من حدث فين؟ ممتاز. أوكي. شغال. السلام عليكم. I'm Dr. Ruzan Radwan. I will present today the introduction for the pharmacy, some cases, the statistic, and ASR, adverse drug reaction, and allergic. First of all, organization chart in our pharmacy. We have multi-units like drug information, continuous education, automation, OBD pharmacy. OBD pharmacy having a subunit like medication safety consultation, acute kidney pharmacy, OBD, central emergency. And also for the inpatient, we have several units and IV. Our vision is to prove oriented pharmaceutical care of highest quality and cost effectiveness for the patient. Our mission in the pharmacy is to achieve the best outcome for the patient. During Hajj days, the pharmacy unit, all the units is working hour 24 hours per day, all the Hajj season. The statistic of our pharmacy in this only 5 days is reached to 15,000 per day. We are having a prescription for 50,000, and also the medication is around more than 200,000. So the main problem we are facing in the pharmacy is the pilgrims is coming from another nationality, another company, another country. So different company and different medication is arriving in Saudi Arabia. So some patient or some pilgrims coming from India or from all the nationality, having not all the medication, having the same company. This is the protocol from the Ministry of Health to substitute the medication from one medication to another. What is counseling? Why it's important? We are talking about counseling today. I will show you some cases, real cases, and important for the counseling and giving the advice on the side effect, the precaution, the storage, and so on. So we have case of missing medical record, 45 years old female known as heart, blood pressure, diabetes mellitus, heart failure. She's Indian. She coming to the ER without any medical record, without any medication. So in the pharmacy, the HOD contact with the hospital there to bring the file and to bring the medication from it. This is the first case. The second case was case for Spiriva. It's a 17 years old female with non-allergic rhinitis, stage 2 hypertension, and having asthma. She presents in the emergency with worsening of her asthma symptoms. During counseling the patient, when we counseling the patient for the medication, she said she's taking Spiriva orally. The Spiriva, as you see here in the slide, it's a device with the tablet. The tablet, they are putting the tablet in the device and in here. The patient, she's non-Saudi, and she cannot speak English very well. So she took the tablet and swallowed it. That's why she having a worsening of her asthma. From this case, we create something called Mafhum. Mafhum, it's a project. If can I ask you please just to screen the code? Mafhum, it's a project we are created in the pharmacy. It's 100% pharmacy work. This project is to counseling the patient in a new way by the code. So if you screen the code, you will see the counseling in the video we are making in the pharmacy. طبعا في two codes, one for مفهوم اللي هو تبع الصيدلية، وواحد for Ministry of Health تبع أدوية الربو. طبعا nowadays we are working to make مفهوم for all the medication in the pharmacy. You screen it, you can see the video. It's a link that show you to. Okay, but I will decrease the slides. Screen this one. You want me to increase it more? Okay, so I'm continue. The other case is for levothyroxine case. The patient is a female present with its age 43, having a surgery for thyroid. On the system, carbamazole having an active order in the system. So she having the operation and so on. After 3 weeks, we send the medication by Saudi Post. At that day, the consultation clinic contact with the patient to prescribe the medication and to consult the medication. They found out the patient is receiving carbamazole and she having taken carbamazole and she's having a surgery for thyroidectomy. On that stage, they consult the doctor, stop the medication, and follow up the patient. All the cases I present, it's a rare case. It's happening in the Hajj season in the pharmacy. This case is case of methotrexate toxicity. That's why I told you why it's important to consult the patient in a good way. This is an elderly patient prescribing methotrexate, 3 tablets per week. 3 tablets per week. The patient is old. He took the tablet, 3 tablets per day. Once he reached the hospital, he's having a methotrexate toxicity. The methotrexate toxicity, the problem of the methotrexate toxicity, the methotrexate accumulates in all the organs. And the symptoms is appearing after 3 or 4 weeks. So once the patient is reached the emergency, he having gingival bleeding, 24 hours, she have a rectal bleeding. Nowadays, he having renal failure, kidney failure, and heart failure, and neurotoxicity. And he's in coma, he's in ICU. Dr. Man, he's in ICU. Prednisolone and Brindopril. This is a female Filipino patient coming in a Hajj season. The doctor prescribed for her prednisolone. She coming to the pharmacy to dispense the medication. When the pharmacist was consult the patient, they found out she didn't have a hypertension. The doctor prescribed in the system Brindopril, and the patient was when the pharmacist is giving the patient the medication, he told her, "This is Brindopril. It's a hypertension medication." She said, "No, I don't have a hypertension." That's what in that stage they found out the doctor is prescribing prednisolone instead of Brindopril. Case of renal failure. This is also a real case. A girl coming to the ER with the low back pain, 13 years old. The doctor prescribed for her paracetamol and baclofen, 10 milligram BID. It's fine. Are you with me? It's fine. When the pharmacist is consulting the patient to dispense the medication for her, they found out she's having a renal failure. So immediately he contacted the doctor to decrease the dose to 5 milligram once daily. So to resolve all this problem for counseling, in the pharmacy, we make this to consult the patient in a good way in the language they can understand. For example, in the Arabic, Turkish, Chinese, Urdu, French, and Indonesian. Also, we make a code, QC code for antibiotic. Also, we having for 1 tablet, 2 tablet, 3 tablet in different language. I will talk about ESR standard, and this is a very important standard in the Hajj season. First one is the high-risk medication. In the system, I know there is a lot of new stuff. A lot of the stuff is coming from another hospital. So in the system, when we are ordering any high-risk medication, it's coming in a red flag in the system. Localized medication, any medication is similarly in the same box. And we will see a lot because, as I told you, the patient is coming from another country. Sound-alike medication is involved the medication. When we are saying the medication is similarly the same. Adverse drug reaction. We have also the code for adverse drug reaction and medication error. It's automatically coming on the system. Allergic. This is the card for the adverse drug reaction. This is allergic. The card for allergic. You will just write only the name of the medication, the identification number, patient name, age, file number, and nationality. Why we need this card, especially in this season? Because some patients coming to the hospital, to Noor hospital, and they will go another hospital, private or maybe another one. So it's very important to have this card with them. Allergic in the system, we can enter it in the system. Just go to Doctor Desktop, click allergic. This screen will open to you. choosing from this sliding list. Click Save. This red flag will appear to the pharmacist, to the nurse, to all healthcare provider in the hospital. Medication error, it's also, as I told you, it's electronic. Medication error, it's a preventable event. When it's happened, it causes harm to the patient. So we can near miss medication when the error has happened, but we catch it before it to the patient. Significant medication error, when death or serious complication happen to the patient, we call significant medication error. Okay, I have a story for this one. This is a mouthwash. The technician was arranging the medication on the shelf. When he's arranging, he's found out there is a small particle inside the solution. So we make a quality report. After 3 days, Saudi FDA memo to recall this medication, to remove it. What I mean by drug recall? Drug recall, that means stop and remove all the batch from all the hospital, from all the pharmacies. And this is one of the sample of drug recall, aspirin. I finished my lecture. Thank you. You have any question? Shukran.
Thank you, Rodan, and I think the questions will be at the end. Our speaker is Dr. Muhammad Abdul Rashid. He's an internal medicine and nephrology consultant, and he's working as a consultant in the nephrology department at the North Hospital. And he will talk about emergency having too much during the Hajj. He will talk about Malaria.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. We'll start in this lecture for rhabdomyolysis. That's another one. These slides before. This rhabdomyolysis is a Greek word that constitutes of rhabdo, this means striated, myo means muscle, lysis means breakdown. And so, definition, destruction or disintegration of striated muscles resulting in the leakage of intracellular substances of these muscles to outside, to the circulation and the extracellular fluid, and also the intracellular fluid that with high concentration can cause increased decay inside the muscle and go more and more electrolyte disturbance. Breakdown of skeletal muscle fiber, potentially life-threatening syndrome, because it will cause abnormal constitution of intracellular and extracellular important substances, same as hypokalemia, hypernatremia, hypovolemia, and so on. Epidemiology, the instance of rhabdomyolysis varies with underlying cause. Level increase with the disasters, same like earthquakes in war zone. Rhabdomyolysis accounts for 7 to 8% of all new cases of acute kidney injury. Same like compartmental syndrome, excessive playing, and war, earthquakes, and so on, muscle cracks, and muscle injury, and so on, crash syndrome, and so on. What's the causes? Exertional and traumatic, inheritance metabolic, acquired metabolic, miscellaneous, and hypoxemia, and drugs. All of this can cause etiology of rhabdomyolysis, the physical and the non-physical cause. Physical causes such as trauma and compression, traffic or working accident, disaster, tortious abuse, long-term deprivation, occlusion or hyperperfusion of the muscle, in like thrombosis, embolism versus clamping and shock, electric current, a high voltage electric current, lightning, cardioversion in the CPR, and so on. Straining muscle exercise, epilepsy, psychiatric agitation, in delirium state, and so on. Temperature related exercise and ambient temperature, sepsis, narcoleptic, malignant. Also in the Hajj region, there is same-like condition. Metabolic myopathy, McArdle disease, mitochondrial respiratory enzyme deficiency, carnitine palmitate transfer deficiency, and so on. Drugs, toxins, regular and irregular illegal drugs, toxins, snake poisoning, monomyositis, dermatomyositis, infection, and endocrine causes such as hyper and hypothyroidism, systemic infectious shock syndrome, influenza, HIV, hepatitis, and toxicity, electrolyte, syndrome of hypokalemia, hypocalcemia, hyponatremia, hypophosphatemia, and hypernatremia, and hyperosmotic. Also, all of this can cause these drugs, and a long list of the drugs that can cause rhabdomyolysis. We concentrate here in anti-lipidemic agents such as statin and the benzofibrate. Statin-related rhabdomyolysis, the statin can cause rhabdomyolysis directly or indirectly impair production of ATP by the skeletal muscle, or increase energy requirement with the exceed rate of ATP production and also cause deficiency of ATP. Interfere with ATP production by interfering with the coenzymes that cause more and more chronic myositis syndrome. So, what's the risk factors of statin to cause such condition? If there is high doses than that usual, increasing age, female, renal, hepatic, insufficiency, diabetes, concomitant therapy with drug as fibrate and other drugs. Exertion rhabdomyolysis, exercise beyond physical capabilities. ATP demand outweighing supply resulting in cellular membrane breakdown. Intense exercise in normal individual with conscience, such like Hajj, really. Grand mal Caesar, delirium, tremens, physical abuse, contact sport, crush injury, compression. Factors that in the development of exertional rhabdomyolysis will increase more and more effect of this exertional rhabdomyolysis in this condition. Fitness level. If fitness level is low and the exertion is both very high, can cause more and more rhabdomyolysis. Experience with type of exercise being performed, intensity of exercise, type of exercise, ambient temperature, hydration, fasting, associated illness. Cause of cellular destruction of rhabdomyolysis. Direct injury to membrane in the case of crushing, tearing, burning, severe electrolyte disturbance disrupting sodium and potassium pump, muscle cell hypoxia lead to depletion of ATP. Pathophysiology. In case of physical injury or non-physical injury, this decrease intracellular ATP with increased cytoplasmic calcium influx because membrane damage. Calcium will influx to the inside with sarcoplasmic side will causing release more and more of proteolytic enzyme. Increased phospholipase A2, increased calcium dependent phosphorylases, increased nucleases, proteases, free radical, local cells. Compartment syndrome or Ribofusion syndrome will help to form this. If there is destruction of this striatal muscle membrane, will imbibe more and more water from intravascular content to the muscles. This will decrease more and more intracellular fluid. Intracellular fluid is decreased with hypovolemia. Patient in hypovolemia causing acute kidney injury easily in this case. But how to rhabdomyolysis affect renal? The first of one is hypovolemia. Direct renal vasoconstriction with endothelial damage will be received. Renal blood flow will decrease filtration, causing lower filtration rate decrease. Also, release of cytokines myoglobin. Myoglobin will be excised and cause lipid peroxidation. This will direct effect in tubular toxicity on proximal tubule, causing renal valve affection. The leakage of these constituents that filtrated from the glomerular filtration back to circulation and will be high. The urine output is precipitation with 10 force flow protein. This myoglobin, tubular obstruction was distant. And because hypovolemia is perirenal, direct tubular toxicity is renal, tubular obstruction in distal post-renal will cause more and more destruction of this renal by 3 ways: pre and kidney and post. Etiology to show direct toxicity of myoglobin tubular cell, cast formation decrease in tubular blood flow, and also urine, hypovolemia and decreased renal perfusion. All of this can cause similar pathophysiology and influx of extracellular contents such as sodium, water, chloride, calcium. And efflux from damaged muscle, potassium, phosphate, lactate, and other organisms, myoglobin, thrombotabulatin, creatine kinase, and so on. And so sodium will move from extracellular to intracellular, potassium in the reverse direction from intra to extra, calcium from extra to intra, and magnesium in the reverse direction, chloride and bicarbonate from extra to intra, and protein myoglobin from intra to extra. This causes electrolyte disturbance, severe electrolyte disturbance. Myocyte injury and so and hours of ischemia to level permanent historical changes, causing muscle irreversible anatomic functional changes with muscle necrosis. When to suspect rhabdomyolysis? Occur in about up to 85% of patients with traumatic injury. Those with severe injury who develop rhabdomyolysis induced renal failure have a 20% mortality rate. Very high percent of mortality. Multiple orthopedic injury, crush injury to any part of the body, something like hands, lying on limb for long period. No patient found down, long surgery, brown urine. Axiom to sudden collapse during physical exertion carried out under warm climatic condition should be primarily diagnosed as rhabdomyolysis unless and until proven otherwise. What to watch for if you suspect rhabdomyolysis? So you must suspect in clinical base muscle pain, weakness, dark urine, hypovolemia, shock, electrolyte abnormality, increasing potassium, decreasing calcium, sequestrated in injured tissue. Early sign and symptom such as weakness, fatigue, headache, slow augmentation, thirst, muscle cramps, nausea, vomiting, and diarrhea. Will cause this abnormal coloration of the urine. The myoglobin causing red urine. Also, in hematuria causing red urine, hemoglobinuria causing red urine, and the external factor also. There are some drugs. How to be differentiated? All will be positive in deep state. In hematuria, then hemolysis and rhabdomyolysis. Positive, positive, positive. But if this is rhabdomyolysis, will be elevated creatine kinase in concentration of the blood. And hematuria will be a positive amount. Red discoloration. In the hemolysis, will be red discoloration of plasma constituent. If you separate the blood, plasma will be red in cases of hemolysis only. And rhabdomyolysis, creatine will be increased only. In presence of erythrocyte in urine will be present in hematuria only. And so to differentiate between all of this in this image. Approach to patient with red or brown urine in sediment red. If sediment red, يبقى دي hematuria. Supernatant red يبقى deep state. Negative or positive? Negative. Hematuria, benzodiazepine, porphyria, and other combined conditions. In positive, myoglobin or hemoglobin. In myoglobin plasma color will be clear, and the hemoglobin will be red. Diagnosis: when creatine kinase muscle correlate with severity of rhabdomyolysis. If increasing more and more increase of rhabdomyolysis. Normally 140, 145 to 260 units per liter. In cases of rhabdomyolysis, may be seen more than 100,000 of the creatine kinase with plasma half-life half an hour or half days to 1.5 days. Rises within 12 hours of onset, peak in 1 to 3 days, and decline in 3 to 5 days. 5,000 units per liter or greater related to renal failure. If from 5,000 to up, will be suspect more and more renal failure in such a case. In serum myoglobin, the plasma half-life just half an hour, because myoglobin will be excreted in bile rapidly and urine, and so plasma half-life half an hour. Of course, will be present in the circulation from 2 hours to 3 hours just one. Creatine kinase is divided into 3 isoenzymes. Isoenzyme is skeletal muscle and cardiac. This is CK3. This represents 96 to 100% of the creatine kinases. Also, CK1 used in the brain and GIT and genitourinary. CK2 present to the other tissue. Creatine kinase will be increased in the plasma up starting to be in 12-hour muscle injury. Peak in 1 to 2 or 1.5 days and decrease at rate of 30% to 40% per day. Serum half-life is 36 hours. Creatine kinase level decline in 3 to 5 days. If still present more and more after 5 days, this means this rhabdomyolysis continue to occur and more injury to the muscle and other organ or injuries. Myoglobin is 5 to 70 nanogram per milli. Plasma myoglobin measurements are not reliable because myoglobin have a half-life of 1 to 3 hours only and clears from plasma in the urine within 6 hours. Urine myoglobin measurement is therefore preferable than that of the plasma. And so serum creatine will be increased, uric acid increase, leukocytosis increase in such cases, hypoalbuminemia, potassium increase in the urine, sodium increase in urine, calcium decrease, and phosphorus will be increased. Clinical manifestation and complication, early sign, hyperkalemia, hyperphosphatemia, acidosis, hypocalcemia, hyperuricemia, early complication, cardiac arrhythmia, even to cardiac arrest, and this due to electrolyte disturbance. Hypovolemia causing more and more disturbances to the kidney and other organs. Late complication, acute renal failure, compartment syndrome, infection, DIC, hypercalcemia, RDS, and so on. How to treat? This patient must be treated early the hypovolemia because will more and more affect the whole organ, especially that of the kidney. And so, the cornerstone of the treatment must be initiated as soon as possible. No randomized trial, fluid regimen in any age group has been done. Patient with creatine kinase elevation exceed 2 to 3 times of the reference range, appropriate clinical history and the risk factor should be suspected of having rhabdomyolysis. For adult, administer isotonic saline in rate of approximately 400 ml per hour infusion or may up to 1000 ml per hour based on the type and condition of severity. And then titrate to maintain. What is the signs to be seen to see good hydration or not? Maintain urine output of at least 200 ml per hour or 3 ml per kilogram. Because of injured muscle can sequester large amount of extracellular fluid. Crystalloid should be required in such cases. You give maybe more and more fluid and the blood pressure is still low. You must add at this time crystalloid to improve and more intracellular. And so crystalloid requirement must be surprisingly large. Consider central venous pressure must be present. Also, Swan-Ganz catheterization in patients with cardiac or renal disease especially. Repeat creatine kinase and assay every 6 to 12 hours determine the peak of CK level. Composition of reduction fluid is controversial and maybe include sodium bicarbonate, especially in normal saline is used. To prevent renal failure, many authors advocate urinary alkalinization with mannitol and loop diuretics. Check urine pH. If less than 6.5, you must alternate each liter of normal saline, 1 liter of 5% dextrose plus 100 millimole of bicarbonate until pH of the urine will be more than 6.5. So alkalinization of urine, what's the benefit? Decrease precipitation of phosphoroprotein myoglobin complex. This is causing obstruction of the renal intrarenal obstruction. Inhibit reduction oxidation, redox cycling of myoglobin and lipid peroxidation, thus ameliorating tubular injury. Counteract vasoconstriction and causing more and more ischemia to the kidney. Diuretics. When you start to be diuretics, you want not start to use diuretics in case of rhabdomyolysis until you replenish more and more hydration, but overhydration of the patient is better. Not hydration, more and more overhydration. Remain controversial, but it is clear that should be restricted to patient home fluid repletion must be achieved. Mannitol may have several benefits in such a condition. Thus, osmotic diuresis, increase urinary flow, flushing of nephrotoxic agent through the renal tubule as osmotic agent. Discrete gradients that extract fluids have been accumulated in injured muscle. Thus, improve hypovolemia, finally, free radical scavenger. Also, free radicals that cause more and more injury to the kidney, they go more and more removed by mannitol. But you must, during monitor time is being administered, plasma osmolality and the osmolar gap, or difference between measured and calculated serum osmolality should be monitored frequently and survive on discontinued if adequate diuresis is not achieved, or if the osmolar gap rises more than 555 milliosmolar per kilogram. Late treatment is dialysis. What type of dialysis to be referred here is hemodialysis. Peritoneal dialysis is not effective, and hemodialysis must be intermittent or continuous. Is intermittent more than important than that of the continuous? Type. We can remove myoglobin to decrease this complication from the plasma by plasmapheresis. Has no many benefit effect. Removal of myoglobin from plasma by plasma exchange has not demonstrated any effect of this. Yes. In case these cases there is hypocalcemia and may cause tetany. In such cases, this hypocalcemia must be not corrected until tetany manifestation is okay. If you increase the calcium content in intracellular, will be go direct to intracellular substance. Intracellular more and more cytoplasmic injury, more and more muscle injury, more and more rhabdomyolysis, more and more cycle of these abnormalities. Take home message: impairment and reduction of use of ATP is the basic cause. Most useful laboratory finding is elevated creatine kinase, 5,000 units per liter, related also to renal acute renal failure. Initial detection of myoglobin, management aggressive hydration, diuresis, urine alkalization, free radical intervention, and dialysis. Don't treat hypocalcemia unless there is symptoms develop. Conditioned by regular exercise to prevent white color rhabdomyolysis. Thank you. Any question?
Question would be obtained to and our next lecture while she waiting for Victoria Rula, we can do your question with Victoria Ruzan and Victoria Muhammad. Victoria Ruzan, you can comment what is the most common type of medication error during the Hajj?
As I told you in the presentation, the most common is coming from the counseling, the communication with the patient, and the different company coming from another country.
What about system? Our system to report such? We have an effective system, and all the physicians they are familiar with that system or not?
As I told you, online we have QCR for verification error, and also it's the health online that's our.
Do you have any data about the reporting during the Hajj season or not?
Sure, we have all the medication or all the health documented in the parts.
And thank you, Ramazan. And for Dr. Muhammad, just you mentioned we don't need to treat hypocalcemia unless the patient is symptomatic in case of rhabdomyolysis. Can you explain why for our junior doctor, please?
In case of muscle injury, this rhabdomyolysis is extreme on each side, and so the extracellular calcium side consequences to intracellular muscles. This calcium will induce sarcoplasmic degeneration will create enzymes that will more and more damage to the muscle. More and more damage to the muscle will cause more and more big water from outside. And so, if you give calcium that increase in the intracellular, the extracellular substance, يبقى more and more calcium will be good inside, and more injury to the muscle will be okay.
And from your experience, what is the most common cause of rhabdomyolysis during the Hajj?
Al-Hajj region, there is many Hajj pilgrims here go to the Arafah and the other side in the hills walking. With this hot climate, goes and more the patient without good hydration in this time, and so this more and more liable to muscle injury and bone. Many برضه person can take in statin because of age due to مثلا taking statin due to مثلا cardiac causes or hyperlipidemia and so يبقى statin present, and do more and more exercise, more and more complement that body physician of this pilgrim, because he has weak muscle, a hot climate, long distance that walk, all of this not good hydration, all of this can cause easily and rapidly to rhabdomyolysis. And so we advise patient, all pilgrims, to take more and more hydration fluid, not to go here and there and walking, must use the other mechanical presence that اتوبيسات وغيرها حاجات دي حفلاتها افضل ما يمشي. This will decrease this muscle exercise and works in the muscle, will decrease هذا كده liability to causing rhabdomyolysis in such a case.
And it's common to see a healthy patient without any comorbidity presenting with rhabdomyolysis secondary to heavy exertion.
Yeah, this is rare, but present in some cases. Maybe have any مثلا diseases like renal disease, hepatic disease, cardiac disease, and so ATP in such a case we call low. And if low ATP, more easily the muscle will be affected by any other cause.
Thank you.
Thanks.
And we'll have our next speaker. She is Dr. Ola. She is our nephrologist and general medicine consultant. And she is interested in the teaching and education. She has a nice experience in Abscessing teaching hospital in Egypt, and now she is the scientific coordinator of our Welcome, Dr. Ola, and she will talk about the common debatable question: what is the best fluid management strategy in acute kidney injury? It's either or liver. And during this presentation, we'll know what is the best fluid management strategy in acute kidney injury. Dr. Ola, the floor is yours, and you are most welcome.
Thank you for inviting me to this great conference, and I'm happy that we return back after this pandemic to our usual life, and Hajj returned again, and I hope this will not happen again at all. أنا حاسة إنه في إيكو في الصوت، مظبوط؟ كده خلاص؟ أوكي. Fluid therapy in acute kidney injury, liberal or resuscitate. Is there any doctors intensivist here? No one intensivist here or nephrologist? Okay, anyway, this is a story of everyday story. We always have more than 4 to 5 cases per day, and we quarrel between nephrology and internal medicine, or mainly the intensivist for this case. This patient overhydrated or dehydrated. How we assess that? We are depending just on CVP if the patient critically ill in the ICU, and nowadays you are not putting CVP for the patient. So this is a very debate story, and every day we are quarreling about it, and no big studies. When I searched to make this lecture, it was so interesting that I didn't find any studies from the nephrologist. Most of the studies done from the intensivist, not from the nephrologist, okay? So it was so important that we focus as a nephrologist on this point. This patient hydrated or dehydrated? What about his fluid status? I'm rushing in dialyzing him to ultrafiltrate him or not. As a nephrologist, you know, there's no nephrology intensive care until 3 years ago. Now there's a fellowship in the International Society of Nephrology for 1 to 2 years for nephrology intensive care. And European Society of Intensive Care Medicine began since 3 years also to make courses, accredited courses in nephrology intensive care, which we needed it a lot in COVID pandemic. Let us begin. I will not introduce myself, Dr. Hussein, thank you, you introduced me, how I move this. We have cases like these cases. You are on medical round reviewing 60-year-old male with presumed pneumonia. You note from recent blood tests, creatinine has risen from 100 micromole to 180 over 48 hours. He has become increasingly breathless over the last 24 hours. This is the case. Another case, you are providing surgical ward cover. This is not ICU cases. This is cases all of you find it in the ward. Okay, surgical ward cover. You are called to see patient 24 hours post colectomy. Blood pressure has been lower and urine volume have been 20, 25 per hour, 10, 20, 10. It's decreasing last 6 hours. Okay, what will you do? So let us begin our objectives. Introduction. I will begin my introduction first. In 1832, Robert Lewins described the effect of intravenous administration of alkaline salt solution in treating patients during cholera pandemic. He began in the cholera. He observed that the quantity of solution will depend on the quantity of serum loss according to the loss. So he replaced this loss, and until now, this is our issue. First of all, we have to replace the loss. Correction of intravascular hypovolemia is a key component of the prevention and management of acute kidney injury. And excessive fluid administration is associated with poor outcome, including the development and progression of acute kidney injury. There's growing evidence that fluid administration should be individualized and take into account patient characteristic, nature of the patient, age of the patient, obesity, body weight, all the other factors has to be considered. You are acting in the medicine now case to case. Every case different than another case. This case today is different than the same case after few years. Fluid therapy in acute kidney injury. Fluid should be only administered until intravascular hypovolemia be euvolemic. Don't overhydrate the patient and don't keep him dehydrated. Using the minimum amount of fluid required to maintain euvolemia. Oliguria alone should not be viewed as a trigger for fluid administration. If the patient is becoming oliguric, that doesn't mean he's dehydrated or he lost volume. We have physiological oliguria. If fluid overload occurs, fluid therapy needs to be discontinued and fluid removal using diuretic or dialysis or renal replacement therapy should be considered. We have physiological oliguria, fall in the urine, has a circulatory response mediated by sympathetic, fall in GFR, and activation of the renal angiotensin system and vasopressin. Also, any other stress factor will stimulate the vasopressin, will make vasoconstriction to the afferent arteriole, will make oliguria. That doesn't mean that this patient is volume depleted. Okay, we have to put this in consideration. Pathological mechanism of oliguria, we have pathological factors, this depending on the renal perfusion, depending on vasoconstriction, depending on filtration pressure and damage, how much damage to the glomeruli and to the tubules. Tubules begin with injury, like pre-renal at the beginning, then after that, there's inflammation, maybe end in obstruction, maybe end in necrosis, as tubular necrosis. Okay, we are coming now to the most important point. I searched for it last week for this lecture. How to assess the volume status? How to know this patient hydrated or dehydrated? Of course, we have clinical, we have examination, we have science to be examined, okay, and we have technology to use it for that. How we are going to assess that? All of them, and we have lab, all of them together. Don't depend on one parameter. Never, ever. You have to collect the whole case together. Volume assessment, if this patient, relative hypotension, tachycardic, low jugular venous pressure, no fluid taken, no edema, dry chest, increased capillary fill time, Okay, history of diarrhea. This patient mostly is not overhydrated at least. But on the other side, if this patient hypertensive with edema but normal albumin, edema with normal albumin, this is a very important point. Edema with normal albumin by basal crackles taken about 6 liters in the last 24 hours. This is too much. Recent intravenous fluid administration, documented weight gain. You have to know what is the dry weight of the patient. Documented weight gain last few days. Okay, mostly this patient is overhydrated. Sometimes you have mixed comorbidities, and this needs more workup, more experience from us. If this patient has hypoalbuminemia, okay, hypoalbuminemia cause that oncotic pressure will decrease, the fluid will go to third space and to the interstitium. Whatever you give fluid will go to the third space, pleural effusion, pericardial effusion, interstitial edema, but you have intravascular collapse. So this patient is not overhydrated. This patient has mixed comorbidity, has to be corrected well. Okay, venous insufficiency, acute lung injury, poor cardiac or autonomic function. This is mixed comorbidity, need experience, work up, well work up. We have measures, we have to put it in mind, and everyone who's going to assess the patient hydration has to know this measures, especially the intensivist and the nephrologist and the internal medicine doctor. The static measures, and I will talk about its details, and the dynamic measures. Only patients who show significant increase in the stroke volume. Do we measure stroke volume when we assess the hydration condition of our patients here in Noor? I think this is too, we don't do it too much here, okay? Increased stroke volume following fluid challenge are considered to be beneficial fluid responders. We have very important title, who's the fluid responder and who's not responder. If he's not responder, why you are giving him fluid? You are injuring the organs more. In the non-responder, volume expansion will only exert adverse effect without any hemodynamic benefit. We need to determine whether a patient will be fluid responsive or not before fluid administration. This is an important issue. Observing if changes in cardiac preload will change of cardiac output, stroke volume. If I'm giving the fluid and this patient is not increasing in stroke volume in the cardiac output, mostly he's not responder. So why I'm giving him fluid? I'm causing more injurious effect on the organ. I'm considering congesting him, impending pulmonary edema, causing congestion to the GIT, congestion to the lung, congestion to the kidney, as we are going to see now. So according to the International Society of Nephrology, and this was in 2017, okay, every patient with acute kidney injury should be assessed for volume status as a part of the hemodynamic optimization by clinical parameters, paraclinical parameters, static and dynamics. All of them are important, but I want you to consider some important issue. Clinical, everything important. Body weight, input, output, blood pressure, urine output, capillary, organomegaly, pulmonary edema. Paraclinical, we can do it and we can, according to our equipment present, according to what we have available. Okay, urine index, fractionated sodium, hematological changes, bioelectrical importance, lactate, so important, and SpO2, which is the venous oxygen going to the heart, not going to the tissue. I don't want the venous oxygen going to the tissue. No, it is coming from the tissue, returning back to the heart. Extravascular lung water index, which we can see in the X-ray and better in the CT. Static measures, CVP, pulmonary artery occlusion pressure, and diastolic volume and systolic volume. This is intra-aortic blood volume index and global diastolic volume, which is more important, the dynamic measures, which is stroke volume, aortic flow velocity, positive pressure ventilation, and microcirculation evaluation. These parameters, I don't want all of you to know all of them, but at least you have to have an idea about some points of them. The stroke volume is important, clinical condition is important. CVP is the one title from other title. We can't consider it, okay? And we have to put in mind as we can to assess all of them together with the lactate level. This is the same what I said before. I'm not going to repeat them again. But when some examinations, we have to consider if the systolic blood pressure less than 100, heart rate more than 90, capillary fill more than 2 seconds, respiratory rate more than 20, and Muse, which is the end diastolic volume, also more than 5. Volume assessment technology. This is one of the technologies we are going to talk about. One important of them, straight leg raise, pulse pressure variation, thermodilution, esophageal Doppler, echo. Echo is available for us. Cable ultrasound also, this is available for us. Okay, here, this part, which I'm going to say it now, it is important. I think it's important. It is a little like workshop. I want to say it. Static and the dynamic. Static means we are going to, this is a single factor. We are going to take it in consideration. Dynamic, this is the relation between the heart and lung. Okay. We know if there's a normal person with a normal heart, if we are going to measure the CVP of this person and we found this CVP is low, so this patient mostly has hypovolemia. Okay, this is a normal person. But if we have a cardiac patient, if we have left ventricular hypertrophy, if we have tricuspid incompetence, pulmonary hypertension, already this patient has high CVP. Does that mean that his fluid is euvolemic? No. If this patient has high CVP, that doesn't mean that he's overhydrated or even hydrated. Maybe he needs more fluid. So we can depend on the CVP in this condition. So they considered after that CVP, high CVP, it is an important factor for mortality. It reflects mortality, but it doesn't reflect the hydration state. It is one parameter from more than 20 parameters. So as we said before, we can consider CVP a normal person, but not in critically ill patient or even in any patient in the ward. Okay, CVP may be used to guide fluid balance less than 12 hours into septic shock, but become unreliable marker of fluid balance thereafter. This was before. Now it is we can't depend on it. This is since 2011. CVP more than 8 may decrease renal blood flow and associated with increased risk of mortality and acute kidney injury. Maybe increase the risk if it is high, but it does not reflect the hydration state. Okay, there's no data to support the widespread practice of using central venous pressure to guide fluid therapy. This approach to fluid resuscitation should be abandoned. Okay, so if I want to assess the fluid state of the patient, he's a responder or not responder, I have to put in consideration, as we said before, the vital signs, heart rate, blood pressure flow, hypoperfusion. If urine output is decreasing, at the same time, I have to assess the capillary filling, the weak pulse, at the same time, the skin, what about the skin and dry mucous membrane, some lab as increasing creatinine, transaminases, lactate, and hematocrit. If there's concentration in the hemoglobin. Okay, we took all parameters together. Type. If this patient responder or not, who? This patient on ventilator or he's not on ventilator? This is going to be different. If he's on ventilator, we can assess the dynamic and the static measures. If he's not on ventilator, we can depend on these. There's another parameters. If this patient is on ventilator, when heart send the blood to the lung and lung is going to be inflated, so the intrathoracic pressure will increase. So the blood returning from the inferior vena cava and superior vena cava will decrease. So the cardiac output and stroke volume will decrease. At the same time, vice versa. If the lung is deflated, intrathoracic pressure will decrease. That will make suction from the superior vena cava and inferior vena cava to the lung. So the cardiac output will increase and the stroke volume will increase. Following this is what we call it the dynamic parameters. And when they measure these dynamic parameters between the end diastolic and the peak of the systolic, which is the pulse pressure, they found that this reflects if the patient is a responder or not. If it is increasing more than 13%, that means this patient needs fluid and he's going to respond. At the same time, when they did this, they calculated the stroke volume, and when they measured the difference between the end systolic and diastolic and increasing more than 13%, also this patient is going to be responder. Okay, so this dynamic measures, it is so important to diagnose the responder to fluid therapy, but it has some conditions. It should be not on spontaneous ventilation, and tidal volume on the ventilator not less than 80 ml per kg, no arrhythmia, No open operation in the chest or low compliance. This is for ventilated patients. Okay, if this patient is in the ward or not ventilated, what we will do? Non-invasive maneuvers depend on the ultrasound. Here, the ultrasound can measure the inferior vena cava diameter, the vein diameters, collapsed or dilated, and the velocity in the aorta movement. Okay, the difference between these, they can assess if this patient is hydrated or dehydrated. I'm not going to talk about details, maybe it's not important for you, but ultrasound assessment for the collapsing of inferior vena cava, for the velocity of the aorta, it is important to assess if the patient is hydrated, responder to fluid or not responder. Also from the measures, if the patient is awake and he's on spontaneous ventilation, they put him about 45 degrees and make a test, leg rising. When we rise the leg of the patient, as we are giving him fluid from 500 cc to 750 cc. When we do that, they after that assess the cardiac index and stroke volume. If it is increasing, that means he is fluid responder. This is for the ward patient or if the patient is in ICU, but he's not on ventilator. But if we can't move his leg, if he has fractured femur, we can't move his leg, we can give him little fluid 250 cc and assess the stroke volume after that. So mainly we are going to depend on echo, stroke volume, on the ultrasound to assess the hydration state of the patient. We are not going to depend on CVP, besides, of course, the clinical points and the other signs as we said before. So at the end, this leg test, an increase in the cardiac output more than 10% predict the response of volume expansion. Meta-analysis of all studies with the test confirms a strong reliability. Okay, what is the types of fluid we are going to use? As we know, we have crystalloid, we have colloid, okay? But I want to talk a little in details. If we are going to give bolus for the patient, either we give lactate or we have saline, usually, or dextrose, okay? But we don't begin bolus with dextrose, except in some cases, I will talk about it now, okay? We know that ringer is different from saline in some additive minerals. Saline has 145 millimole sodium in liter, while the normal sodium, average normal sodium in blood is 140. So it is isotonic saline. If we give too much saline to give bolus for the patient to resuscitate the fluid, it is okay. But we have to put in mind that too much saline has chloride. Chloride causes acidosis. So we have to consider this in point. Who give too much saline? Usually medicals don't give too much except in special cases, in surgery more. If the patient has burn, if he's going to enter to operation, maybe they can give up to 10 liters, okay? But all of this abundant now, we are decreasing that. Lactate ringer, lactate in 1 liter have more potassium, about 4 milliequivalent per liter. If the potassium of the patient is 3.6, okay, and patient is MPO, he's not eating anything, and you have to keep potassium in this level, you have to give 40 milliequivalent potassium, okay? So if you are going to give him just ringer lactate, you are going to give 10 liters, too much. If the potassium of the patient 3.2 and you are depending on ringer lactate, you are going to give double, 20 liters. This is too much. We don't do this in medicine, but can occur sometimes in some cases, surgical cases. We have to consider that more ringer lactate, this will play in the potassium level. The rate according to the case. Yani if I have an 80 years patient with, we don't know the cardiac condition, I will not give her fluid like the 20 years old person. If I have burn patient, I will not give him fluid like another one who doesn't have burn. Maintenance fluid, usually we have half saline dextrose, quarter saline dextrose, and usually we have special equation to measure how we give maintenance, and I wrote the equation here, 500,000 plus the body weight minus 20 over the 24 hour, usually it is about 75 to 150 milli per hour. This is maintenance. If we have more loss, we will add that. If we have other comorbidities, we should put it in consideration. 90 years old patient, not like 20 years old patient. We have to put all of this in consideration. Okay, when I give free water, this is orally by NGT or something. If I want to give it IV, it is dextrose, D5. Okay, when I give water, when I have dehydration, and we have to understand volume depletion is not dehydration, and dehydration is not volume depletion. Dehydration means that I lost the body water from the extracellular, intracellular interstitium. While volume depletion, that means I lost the fluid from the extracellular volume with electrolyte. There's a difference between both. Usually we talk about dehydration as volume depletion and about the volume depletion as dehydration. They are not the same. And their correction is not the same. When I have volume depletion, I will give saline. When I have dehydration, I will give D5, because usually this dehydrated person, if he is eovolemic, he has high sodium. Okay, this patient is dehydrated, but continue dehydrated. He's old patient, he's not eating, not drinking for a week. He will have volume depletion. He began with dehydration, later on reflected to volume depletion. Okay, what I will do, how I will correct him? How I will correct him? Give him saline or dextrose. He has high sodium, but his volume depleted. Okay, we have to correct volume depletion first. So we will have to give normal saline until he's eovolemic. Then after that, we can give D5 to correct the hypernatremia or half saline. It's okay with you? It's okay? Okay. Here's the difference between هي دي مش عارفة بمسكها ولا أعمل إيه. 5 minutes. طيب. Clinical pictures إن إحنا difference between both of them affect the mentality, volume depletion, altered mentality, hypertonicity alter mentality more. Orthostatic will be altered by volume depletion, but will not also affected by hypertonicity, like in dehydration. Thirst will be affected a little in volume depletion, but more with hypertonicity. Supine position tachycardia will be affected more in volume depletion. Hypertonicity is not going to be affected. Dry mucous membrane and the axilla will be affected more in hypertonicity. Longitudinal tongue folds will be affected with hypertonicity. Let us take the important point from the lab. Okay, hypernatremia will be affected by hypertonicity, elevated blood and creatinine with volume depletion more, decreased urine sodium with volume depletion more. And the treatment, as we said before, fluid type, isotonic saline for volume depletion, free water for hypertonicity, rate of administration fast and slow. Okay, as we said, if we have crystalloid or colloid, we would prefer crystalloid for the colloid. This is ended according to the last studies. If we have HEST, don't use it. Dextran and gelatin, not studied. Albumin, no beneficial effect except if the patient has severe hypoalbuminemia. Normal saline, still the standard, but balance the crystalloid now, no harm to effect and may decrease the risk of acute kidney injury. Resuscitation of fluid, we have first to assess the patient and rescue. This is life-saving and should occur in minutes. After that, you have to optimize the patient, his responder or not, and give him the fluid according to the need. After that, you have to stabilize the patient, and this takes days. Aim to 0 to negative fluid balance. Re-exhalation, organ recovery, he's recovering, and you have to take fluid slowly and begin on oral therapy. Average fluid now, it is 3 to 4 liters in 48 to 72 hours. Before, we are giving more and more. Okay, what is the target from my lecture? Fluid overload, now we have to avoid it as much as possible, because the danger here, like pulmonary edema, and this overload will affect the whole organs, the brain, the lung, the kidney itself. And this interstitial edema will happen due to hypotension. This will affect the sympathetic, and this will make more salt and water retention, hypoalbuminemia, oncotic pressure will decrease, so we have third space. Damage of the endothelium that will cause leakage, and this is the vicious circle relationship between fluid intake and output. This is what causes edema. But if the patient has fluid overload, you have to assess this from the fluid chart. This is the nursing work, which is so important, more than the body weight. And if there is increased fluid, more than 10% of the body weight, this is increased the risk on mortality and risk on acute kidney injury. And this is proven by many studies, 2012 and 2008 and 2006. Fluid overload is too harmful for the patient, to the kidney also, because the kidney is not a free organ. It's not free like the liver, it has capsule. And when the fluid increases in the kidney, the intraglomerular fluid will increase. And this will make more pressure on the glomerulus, more pressure on the afferent arteriole. This will cause damage, more damage for the kidney. So prevention therapy, of course, you have to assess the patient well, avoid giving more fluid, and at the same time, I don't want the patient dehydrated. So you have to optimize the patient. You can use diuretic when there's fluid overload. This is an important point. Don't use it if there's no overload. No role for diuretic. It will be harmful for the patient. We don't recommend it for that, except if there's fluid overload. Volume diffusion, a major risk factor for acute kidney injury, and volume overload, as we said. Fluid therapy, we give the fluid for the patient. You have to assess what is the bolus, what is the maintenance, who's the responder, who's the not responder, to avoid harming the patient. And if the patient is oligouric, you have to follow him strictly, very strictly. And you have to assess this physiological oliguria or pathological oliguria. Okay. Medical therapy, if he has hypervolemia, of course, we will restrict the fluid intake, give loop diuretic, and consider the forced diuretic dose. This is an important, from 80 to 100 milli per hour. This is the forced diuretic dose, and force the patient for 2 to 6 hours. If he passed urine in the first 2 hours, okay, he's responding to diuretic. If he's not passing urine, he's not going to be responding, and prepare the patient for dialysis. Reduce preload with nitrate to create supportive therapy, and prepare the patient for renal replacement therapy if he needed. Last point, restrict or liberal. Okay, according to the studies before, they said that restricting the fluid is injurious for the kidney. And this done in this study 2016. Don't restrict fluid for the patient. After that, restrictive versus liberal fluid administration during major abdominal surgery. It caused acute kidney injury 8.6%, while liberal was 5%. So liberal was better. And last study in 2021 in PubMed, restrictive fluid management versus usual care, liberal usual care in acute kidney injury, a pilot randomized controlled study. This was the conclusion. In a critically ill patient with acute kidney injury, restrictive fluid management regimen results in lower cumulative fluid. They preferred restriction. Okay, so this is if anyone want to follow how to give fluid for the patient with acute kidney injury. At the end, what is our issue from this lecture? Previously, we give aggressive fluid replacement. Static measures was the measures we depend on. We give normal saline and a protocolized approach. Protocol for the whole patients. Okay, then the new measures now, present measures, aggressive prevention of fluid overload, but don't keep the patient dehydrated. Dynamic measures with the patient to be fluid responsive or not. His fluid responsive or not has to be assessed. Balance the crystalloid, not saline, is preferred. Individualized approach, case to case, time to time. This case, even it's different than the same case after a few weeks. Okay, take home message. One size doesn't fit. One size doesn't fit all. Both hypervolemia and hypovolemia are bad. Thank you. So.
Thank you, Dr. Roda. Any question? Any question from the audience, or I have to the chat, or anyhow? I have a few questions for you that sometimes practically we stuck with patient, he is dehydrated and he's at the same time is hypernatremic.
Yes.
What is this kind of fluid? Can we use either normal saline or half normal saline or fourth normal saline? How we can overcome this practical question? Commonly they ask if the patient dehydrated and hypernatremic, what this kind of fluid can we use?
We have to assess, as I said before, is volume depleted, this patient, or not. If he's not volume depleted, we are going to give dextrose 5 or half normal saline. If he's volume depleted, we are going to give saline, as I said first, until he's eovolemic. Then continue after that by half saline or dextrose 5.
So, and another question that what is the best way to assess the volume status of the patient? You would go with the invasive or just to check the vital sign, or we have to do the invasive measure to assess the volume status. Patient need to be rehydrated for acute kidney.
If the patient ventilated or not. This is, as we said, dynamic and better than static measures if he's on ventilator with the all other conditions we said, no arrhythmia, tidal volume less than 8, whatever. Okay, but if the patient has continuous ventilation, we are going to depend on the leg rising test. Besides of that, as we said, the whole measures, examining the patient, okay, signs and symptoms of the patient we have, and lab, the other lab, all of them should be taken all together to assess the fluid condition of the patient.
Yeah, and because some of the invasive measure is not clinically applicable,
Yes.
not available.
So we have to take the all signs of the patient, heart rate, pulse, lactate, whatever I have available, I have to assess by it.
There is a common phase from the intensive is that to keep the kidney all the time wet is better than.
No, this is now, it's not preferred, not wet and not dehydrated. Okay, that's all.
We have to keep the patient all euvolemic as much as
Yes,
we can.
euvolemic.
Many thanks, Rola, for
You're
your
welcome.
lecture.
Thank
And
you.
we will discovery conclude our program and our
Shukran.
for their support. And also I have to thank for our organizing committee, start of leadership meeting, where Dr. Leida Zamani, Dr. Your colleague, Isra, for their support, and all the managing for the technical part related to our conference. And again, many thanks for your attendance, and hopefully you will get more benefit with this conference. And I think there is a confirmation for registration today as well, or okay, no more confirmation. Thank you for your attendance, and hopefully all the ones who attend, they will be registered. But we are lucky that we in the last session and we have in our hall more than 70 attendants, better than نشكركم مرة ثانية، وإن شاء الله نشوفكم قريبا موفقين. and here you are well إن شاء الله. في أمان الله.
مسجلين اصلا، بس احنا جايين عشان خلي قبيلة تفوز معهم. جاية انه عشان يجوا بيانات او عندهم راح نرفع فيها، بس انه زي ما انت كيف شكلنا في طور، لو ما سوينا كذا حنخلص اثنين، صح؟